well. And so, yeah. So, again, thank you very much for being here. I just want to give a thoda sa sandarbh dena chahti hu, little bit of context. I mean, this conversation is not new by any means. All of us know that how we as a country have shifted, ground from at some point a health for all conversation where all health services were to be provided for all people free of cost at user interface to universal health coverage, and then from there on to universal health care, and from there on to universal health coverage, which is more and more becoming defined by simply by insurance. So this is a recurrent theme for debate and for conversation within all our groups, and really nothing new there. I think what we also are pretty clear about is the status at the present moment of time, which I will just go through quickly because there are new people here, new faces, just very briefly. But what we are less clear about, I feel, is how to strategize in this situation, how to move forward, what to do, considering that a clear revolution is not in the offing. So what
Vandana, you're on mute.
from when? From the beginning or from when?
No, just now.
Okay. Yeah. Whoever's putting everybody on mute, yeah, I understand that people come in unmuted and then everybody has to be muted, but keep me unmuted, please. And the speaker. So just be careful, whoever's doing that. I think it's Ananya or Rupa. Yeah, so what I was saying is that the status, अभी हम कहाँ हैं ये काफी स्पष्ट है सबको कि हम कहाँ पे हैं, हमारी स्थिति क्या है। लेकिन ये कम स्पष्ट है कि यहाँ से क्या रणनीति निकालें, यहाँ से क्या हम इंतजाम करें, किस चीज़ के लिए लड़ें और किस चीज़ के लिए बोलें, because it's a very complex situation. So we know all these things. What I'm just laying down very, very briefly, it's a very summary kind of thing that I'm trying to do for a very complex situation, but you will understand what I'm trying to say. So we know कि स्थिति ये थी कि हमको मुफ्त में सारी स्वास्थ्य सेवाएं मिलनी थी. The public health system was meant to be free and is actually still meant to be free. I don't see that there is anywhere that it says that it's not meant to be free, but in practice we all know that that is absolutely not the case. So user fees are everywhere in the public health systems. Some things you do get free, some things you don't get free. But broadly, we know that everybody spends out of pocket. सबका जेब से खर्च हो रहा है, and that is what this whole out of pocket expenditure, business is all about. So that is one thing. The public health systems are under funded, under budgeted, and but they're still supposed to provide free services, but they're not doing so. And whoever goes there is having to pay out of pocket. At the same time, private sector है, which is largely unregulated. वहाँ पे सेवाएं कुछ मिलती हैं, कुछ नहीं मिलती हैं, लेकिन उसमें खर्च बहुत ज्यादा है. एक तो खर्च बहुत ज्यादा है और ऑल्सो ये भी पता नहीं होता है कि वहाँ हमारे साथ क्या हो रहा है. So we are really not able to establish whether the care given to us is rational, needed, so on and so forth, and the cost is horrendously exorbitant. So ये स्थितियां हैं. अब इसी में सरकार क्या कर रही है? तो सरकार कई चीजें कर रही है, छोटा मोटा सुधार भी करती है, छोटे मोटे बजट्स भी एलोकेट करती है, और कुछ कुछ स्कीमें भी चलाती है. अब पिछले कई सालों से हमको मालूम है, वी नो फॉर अ फैक्ट दैट द मेजॉरिटी ऑफ द बजट इज रियली गोइंग इनटू पीएमजेएवाई, विच इज अ सोशल हेल्थ इंश्योरेंस स्कीम, जिसके तहत कुछ लोगों को सीमित तरीके से सम वेरी फ्यू पीपल आर बीइंग एबल टू अवेल ऑफ दिस स्कीम, बिकॉज कंडीशनैलिटीज ये हैं कि ढाई ढाई लाख से कम आपका सालाना आय होनी चाहिए. So 2.5 lakhs or less, annual income, and so on and so forth. Many conditionalities, and also conditionalities of needing ration card and so on and so forth. So it's a very limited kind of set of people who are able to avail this at all. ये भी स्पष्ट है कि जिनको ये मिल भी रहा है इंश्योरेंस, उनको कहा जाता है कि आप एम्पैनल्ड प्राइवेट में भी जा सकते हैं, पब्लिक में भी जा सकते हैं. Public facilities are not necessarily able to compete for obvious reasons with private facilities. Many of the patients go and spend their money in private facilities, and yet at the same time, the out-of-pocket expenditures do not necessarily go away at all. So costs still remain, but they do have slightly better access to private facilities. And so in the community, those people who avail, they seem to like it. मतलब I have heard this from many people. जो लोग यहाँ जमीनी काम करते हैं उनको मालूम है कि जिन्होंने इसका इस्तेमाल किया है वो काफी सेटिस्फाइड भी होते हैं और बहुत से डिससेटिस्फाइड भी होते हैं. So in this very complex situation, many schemes have come up and some schemes have been state specific. So I want to explain to you why this webinar is talking Rajasthan and why is it talking social health insurance. तो जब स्टेट स्पेसिफिक स्कीम्स की बात आती है, जब स्टेट्स की बात आती है, राज्य सरकारें अपना पैसा लगा के कुछ भी कर सकती हैं, जो भी अच्छा काम करना चाहती हैं वो कर सकती हैं, एंड सम डू सम थिंग्स एंड सम many do not much at all. Now when we talk of state differentials, normally conversation में ज्यादातर केरला की बात आती है, but for many, many conversations we hear that Rajasthan has also set up many specific state specific schemes जिसमें राज्य अपना पैसा लगा के कुछ कुछ कर रहा है। तो मुफ्त दवाइयों की योजनाएं हैं, मुफ्त इन्वेस्टिगेशंस की योजनाएं हैं, जो पीएमजेवाई वो तो है भी, और एक और भी स्कीम उन्होंने चलाई थी, चिरंजीवी स्कीम, जो सब जिसके लिए सब कोई एलिजिबल होते हैं, जिनको पीएमजेवाई में कवर भी नहीं किया जाए जा रहा है उनको भी उसमें कवर किया जाता है। इस स्कीम का नाम बदल के अब मुख्यमंत्री आयुष्मान आरोग्य योजना कुछ ऐसे कर दिया गया है। बट दिस स्कीम, उसमें कुछ पैसा उनको भी डालना पड़ता है, अराउंड आई थिंक 850 रुपीज दे हैव टू पे, एंड द रेस्ट इज पेड बाय गवर्नमेंट, एंड सो दे ऑल्सो गेट सम कवरेज ऑफ 25 lakhs. So there are many these schemes of something being done additional to what central government is doing in Rajasthan, and we know that Rajasthan is one of the states that has been able to bring out the Right to Health Act, even though that is not yet, rules नहीं बने, implement नहीं हुआ है. And Narendra Gupta, who has been raising these issues, that there is something happening in Rajasthan that we need to take stock of, and we need to understand that. So putting these things together, the larger conversation about social health insurance, जिसमें अभी जो हाल का जो conversation था was really struck by comments about Chiranjeevi scheme as a, as a something, as a movement forward that the state government has done in Rajasthan. We thought we should really revisit this whole thing, maybe talk about Rajasthan a little bit more, give it a chance to describe all that has happened, that seems to be innovative or new or better for people, with its complexities, challenges, and its limitations. Many people have pointed to all these limitations and so on. And then discuss social health insurance in particular in a more academic way, which is what Jean will bring to the PSI Asia Pacific. Please, could you mute yourself? PSI Asia Pacific, could you please mute yourself? Thank you. So this is how it's going to go. This is the context of this. It's called a learning webinar, क्योंकि मतलब अपने बारे में कह दूं, मैं बिल्कुल भी कोई विशेषज्ञता सोशल हेल्थ इंश्योरेंस में स्पेसिफिकली नहीं रखती हूँ, और ये काफ़ी कॉम्प्लिकेटेड चीज़ है। इसमें बहुत से आंकड़े इन्वॉल्व होते हैं। देयर इज अ लॉट टू अंडरस्टैंड इन टर्म्स ऑफ डेटा, इन टर्म्स ऑफ इकोनॉमिक्स, माइक्रो एंड macro, and that's one of the reasons why we really thought it'd be very valuable to have Jean here as a development economist with so much work on this, and he has been also putting things on the group in JSA Discuss. Many others have also shared tables, data, Chaya, Akshay. Many people have contributed to this discussion, Sundaraman. So I hope that they're all here. It's a group of well-informed people, experts really. कुछ ज़मीनी काम में एक्सपर्टीज रखते हैं, कुछ एकेडमिक काम में एक्सपर्टीज रखते हैं, सभी कोई स्वास्थ्य के काम से जुड़े हुए हैं। तो आई होप द डिस्कशंस विल बी रिच। सो व्हाट वी आर गोइंग टू डू इज, नरेंद्र जी से हम पहले बोलेंगे कि राजस्थान इज अ केस स्टडी फॉर moving forward on whatever it is you want to call it, health for all, universal health care, universal health coverage. And then we can maybe discuss that very briefly. Then we'll move to Jean to talk about social health insurance in a broader sense. And then we shall open out the discussion. We hope to have, say, if a maximum of 1 hour for the speakers with some interposition of questions in between, then a whole hour really for discussion. So that sounds good to me. So let's just move ahead without any further ado. And I'm not going to introduce the speakers. They can introduce themselves in the way they want to. I think they're very well known. And all of us sitting here, we kind of know each other. So Narendra ji, welcome to you. Please share your slides and let's talk about what's happening in Rajasthan, the pros and cons and the complexities of it. So over to you, Narendra ji. You have a
ओके
50 minutes.
थैंक यू वंदना, बहुत ही इलेबरेटली आपने सब कुछ ऑलरेडी बता दिया है। वैसे तो नाउ नॉट सो मच ऑफ और बाकी है, तो मैं ये अनन्या, इफ शी कैन open my slides, then it will be better because I still have to struggle to find where my slides are. Rupa, yeah. So तो पहले तो बहुत बहुत धन्यवाद एंड टू ऑल द participants who are part of this webinar. It's wonderful to have you all to come and listen to us. तो सबसे पहले
फ्रीज हो गए हैं या किसी ने म्यूट कर दिया गलती से?
1980, तो ये वो बिल्डिंग है जो कि 1980 में जिस गांव में मैं रहता था और हम काम करते थे उसमें ये बिल्डिंग थी। और इस बिल्डिंग को बनाने में, इसकी नींव खोदने में जॉन रेज हैं वो 15 दिन तक नींव खोदते रहे, पत्थर निकालते रहे, पत्थर तोड़ते रहे। उन्होंने वो मैसनरीज को भी, मैसन्स को भी ये पत्थर जा जा के पकड़ा है। तो ये बिल्डिंग बनाने में 45 साल पहले, 45 years बैक, ही contributed in getting this building built. This was the temporary and the living space for some of us. So I thought, let me show this first to you that Joy and I know each other since that time, not only something very recent or earlier. और मेरे को लगता है शायद उस समय he had just come to India and he had not even met anyone. So this is what I just wanted to say about Joy and me, for that matter. So now coming to the main presentation, we change the slide. So the topic has been assigned by Vanna to both of us. So that is the topic, and as already said in our introduction, कि Rajasthan में something has happened because Rajasthan is otherwise considered as a part of what is called as Bimaru state, and then later on renamed as aspirational states. That is what it was. Can the slide be changed, please? Anyway, anyway, तो अगर ये स्लाइड चेंज हो जाए तो अच्छा है. Can you go to the next slide, please? हाँ या अच्छा, तो मैं ही कर देता हूँ. नहीं, मेरे से तो नहीं हो रहा है. हाँ, हो गया, ओके, वंडरफुल. सो दिस इज द टॉपिक ऑफ द टुडेज वेबिनार. और आप देख सकते हैं कि मेरे से तो नहीं हो रही है. आई कांट चेंज इट.
नरेंद्र जी, अगर आपका स्क्रीन नहीं शेयर हो रहा है तो आप नहीं कर पाओगे ना, फिर तो रूपा ही कर पाएगी, तो आपको रूपा को ही बताना पड़ेगा. अगर
हाँ
आप
हाँ
करना चाहते हो तो
नहीं,
आपको अपना ही
हाँ
स्क्रीन शेयर करना पड़ेगा, है ना
हाँ
वो.
हाँ.
Can
तो
you
ये
see the slides?
राजस्थान इज लोकेटेड इन द नॉर्थ ईस्ट रीजन. इट्स द लार्जेस्ट स्टेट इन एरिया बट 6.7 in country. तो इसका डेंसिटी पर स्क्वायर किलोमीटर इज नॉट वेरी मच. 60% लैंड एरिया एरिड. ESTP, which is in 2023-24 per capita is 1.87 lakhs, which is average of 1.69 lakhs, and it is higher than the states like West Bengal, UP, Odisha, MP, Jharkhand, Chhattisgarh, Bihar, and some
इसको फुल स्क्रीन
largest
मोड
states.
में कर सकते हैं प्लीज रूपा, इसको फुल
बड़ा
Yeah,
प्रेजेंटेशन
I
मोड में
can
कर.
do that, but I think it takes time to ship the slides, so I'll
ओके
do it.
ओके.
Okay. So next slide, please.
स्लाइड शो करके ट्राई कर लेते हैं एक बार.
So Rajasthan is making. Okay.
आप कंटिन्यू करो, वो कर रही है, आ जाएगा.
So Rajasthan is trying to make an effort towards, I could say, universal health coverage, and for that it has undertaken several steps by which it could, improve the access to medical care, especially not so much of the health care. तो इसमें मुख्य बात तो यह है कि we go through the chronology of events. Then we with government of Rajasthan the year 2011. Next slide, please. In
नरेंद्र जी, आप
2011.
अपना वीडियो ऑफ कर दीजिए, क्योंकि ना क्या है, आपकी आवाज ब्रेकअप हो रही है, आपकी
Okay.
कनेक्टिविटी अच्छी नहीं है.
हाँ,
तो
मेरी
हाँ.
connectivity is really
हाँ, तो
not.
आप
I don't know
वीडियो
why. Today only it is happening, otherwise it is always
ये
5G
ऐसे ही
types,
होता है।
huh?
आज मेरा लैपटॉप क्रैश हो गया बिना बात के, कोई पता तब से चल रहा था कई सालों से। चलिए हाँ, आगे
Yeah.
बढ़ते हैं।
तो सबसे पहला जो उन्होंने मेजर स्टेप लिया, वन वन कुड से वाज इन अ ईयर 2011, when it was decided that there should be a free medicine scheme in Rajasthan. So all people who are getting into medical government hospitals, all medicines without any payment, after medicines, they don't prescribe medicines for which people have to buy from outside, and that was the practice earlier. So it was a very big attempt. Why I should say, because doctors vehemently oppose this idea, and why they oppose this idea is all known to us, because they all had certain income coming from while they were prescribing medicine to patients from. And for this, Rajasthan State Medical Services Corporation was established, then supply chain system for procurement of medicines, quality testing, distribution to drug warehouses, district drug warehouses, to drug distribution centers, finally dispensing, and all those things were trying. That thing began, and so what I just want to put it in your notice is this, that the cost for it was very high. Government of Rajasthan was already spending quite a lot of money in procuring medicine, but there was no system in place by which these medicines reaching to the patients. It wasn't happening. But that to happen once this scheme was announced, and the entire thing got streamlined, and the quality of the procurement, quality of medicine which were procured also improved drastically because of the system. Then realizing this, that not too much of money is to be spent, in 2013, Mukhyamantri Nishit Janch Yojana, it's all laboratory investigations were made free. Otherwise, there were a certain amount of money to be paid by people for getting the investigations done, even in the hospital for that matter. So, in 2013, then the government changed. And when the government changed, the new government, which was a different political party, they thought that in competition to this free medicine scheme and free investigation scheme, they should also come with a certain kind of scheme. But they, instead of doing something within the public system, they introduced first time health insurance program called Bhamasha Swasthya Bima Yojana, which was launched in 2015, 15, and it was uh, more or less a copy of Rashtriya Swasthya Bima Yojana, I would say. So cashless treatment up to 30,000 for secondary care and up to 3 lakh for critical illness per year for a family. No restriction of family size or pre-existing disease. But then it was limited to only the families which were under National Food Security Act or enrolled in BPL family. Treatment, of course, could be government hospitals and also in private hospitals. That was the scheme which was launched by uh, the ruling party, which came into being in 2015. So, जब ये में तो all kind of problems people used to face. A large number of people could not make any, despite the fact that government was advertising it, pushing for it, and all kind of things were said. But it was a very difficult process in order to get any benefit out of this scheme. Next slide, please. So after way back in then in 2018, of course, late September 2018, Ayushman Bharat Pradhan Mantri Jan Arogya Yojana was launched throughout the country. But in Rajasthan, that Bhamasha Swasth Bima Yojana continued for a while. But in September 2019, this Bhamasha Swasth Bima Yojana was merged with Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. And then the coverage, of course, was raised to 5 lakh. And in this, about 1.10 crore families out of 1.8 families were covered. and treatment in all empaneled public and private hospitals is exactly as the nationally designed ABPMJ. That is what happened within this. Next slide, please. After 3 years of this, on 1st May 2021, the government changed in 2018 December, and after that in 2021, once the COVID got over, the state government launched a scheme called Chiranjeevi Swasthya Bima Yojana. And this what they said is that under ABPMJ, about 1.10 crore families are already enrolled for insurance of 5 lakh. Why can't we have the other remaining families also as part of it? And so they made a offer to rest of families that if they pay 850 rupees as premium, which is 50% of the total premium, and pays to the insurance company, then they also could get the benefit which the families which are enrolled under ABPM get. And no rider or family size, but highlighted that they have not been able to, whatever money they see, the claims are far less than what they had earlier thought of. So they began to increase the assured from 5 lakh to 20 lakh to 25 lakh. But of course, they were clear division, and clear division was that up to 5 lakh, the claims will be settled through the insurance company, and for remaining 20 lakhs, there will be a trust which is created by the government, and reimbursement would happen from there, or even cashless treatment happen. This hybrid financing system was on for 5 lakh, New India Assurance, a public sector company, and 20 lakh through trust. Next slide, please. So this is the real big thing which happened on 1st April 2022 and then expanded to 3rd June 2022. And this is called Mukhyamantri Nishulk Nirogi Rajasthan Yojana.
You've done the budget and you said target sheet of this.
This Nishulk Nirogi Rajasthan Yojana.
Yourselves, please mute
The budget
yourselves.
is broken up into first year, second year, third year.
Please
Sharad,
mute yourselves.
please.
No, not you,
Costing.
Narendraji. Just, yeah. Thank you.
Okay. So through this is key.
It's unmuted.
All OPD and IPT treatments in public institutions are made free. Absolutely free. No charge of any kind. All user fees removed. Everything was made complete. All kind of investigations, all kind of fees, all kind of other treatments. All of these were made free through this scheme. And that there was a tremendous surge in number of patients seeking care through this. So this is what made a big difference between Rajasthan and rest all of the states in India, and perhaps many countries in the world where they won't have something similar as Rajasthan has. So this is something which happened. So next slide, please. Then, of course, soon after this, the Rajasthan government, introduced this Rajasthan Right to 2022, which was given a set by the governor on April 13, 2023. That guarantee emergency care, in the Act, there were provision of creating a state district redress body, and if violations happen, what exactly a patient could do. Those details are wanted in this.
Narendra ji, we have lost you.
No, I'm back. I'm back
You're back.
now.
Yeah, you're back.
Yeah, am I audible?
Now you are, but आप बीच बीच में टूट जाता है फिर चले जाते हैं तो
हाँ,
हाँ,
ये
कुछ कर
तो
सकते हैं तो कर ही नहीं तो ऐसे ही चलेगा हाँ.
I can't help it
हम्म.
because
कोई
internet connection is unstable.
yeah, let's go
तो
ahead.
फिर उसके बाद when again the government changed, and when the new government came, they changed the name of Chiranjeevi to Mukhyamantri Ayushman Arogya Yojana, and it has the same thing. Now, within this Mukhyamantri Ayushman Arogya Yojana, there are 2,370 treatment packages. According to the Principal Secretary Health statement made in May 25, there are about 8,200 patients are treated daily, costing rupees 9.42 crores. Bifurcation between private not available in public domain. We are trying to this, but it only reflects that the continuity, there is a policy continuity in the new government. The Nishulk Nirogi Yojana goes on the way as it was going on. So, yeah, next slide, please. Next. So, what one could say about the universal health cover model is this: that in government health institution, we have Ayushman Bharat PMJ, Mukhyamantri Ayushman Arogya Yojana, Mukhyamantri Nishulk Nirogi Yojana, that is the free to everybody, Mukhyamantri Nishulk Dawa, and so on. But in private hospital, it is ABPMJ and Mukhyamantri. Now, as Vanna had raised a question earlier कि भाई कोई अगर प्राइवेट अस्पताल में वो सरकारी अस्पताल में जाता है तो why would he she use her insurance money for the treatment when the treatment is free of cost. So that choice is not available to the patient. What happens to the patient is when a patient gets into the hospital for admission, तो वहां पे वो उसका फॉर्म भरवा लेते हैं और उसमें उसका आधार और जन आधार, देयर इज अनदर एंटिटी हियर कॉल्ड एज जन आधार व्हिच इज अ फैमिली कार्ड, नॉट अ इंडिविजुअल कार्ड लाइक आधार इज एन इंडिविजुअल कार्ड, बट जन आधार इज अ फैमिली कार्ड. तो वो उनका वो डिटेल ले लेते हैं, एंड वो डिटेल के बाद it's the hospital which decides whether to treat free or not free, treat the patient in Nishulk Nirogi Yojana or treat under ABPMJ or MA Yojana. It's the hospital which decides, and if the hospital decides that that patient is treated for this insurance scheme, which is the MA or ABPMJ, that at the time of discharge, his or her photo is taken so that they get the evidence and then claims for it. That freedom is not available to the patient. That he is वो आगे कह नहीं साहब मुझे तो free करो, but I am asking scheme. That freedom is not available, but you get all your treatment free, and there is no distinction between people who are insured or not insured in the public hospital. There is absolutely no difference of any kind. So that is the way it works at the moment. Anyway, there could be questions around this, but we can always talk about. Next slide, please. So, total health budget at the 25 is 31,888.06. This is about 1.7% GSDP and 5.9% of the total, 8% of the revenue budget for the financial year 25-26. So it comes to about rupees 3,937 per capita. Out of this, 3,500 crore allocated to MA and ABPMJ, 2,200 crore via insurance route, and 1,300 crore via trust note. That is the way it is distributed. Next slide, please. So pathway to universal health coverage, as I said already, that free care, rare disease, transplants के लिए partially reimbursed है, उसके लिए different. बाकी state residents receive hospitalization on proof of residence, that is Aadhaar or Janadhar, coverage under ABPM may in empaneled public private, even in hospital outside Rajasthan on referral. Government claims that equitable, accessible, and financially protected healthcare delivery system we have. Next slide, please. So this is the most important slide according to me. There's somehow a perception or kind of thing that more patients are seen in private sector and less into public sector. But this is completely wrong as far as Rajasthan. Rajasthan almost 70 to 80% IPD and 70 to 80% of the OPD treated by qualified medical practitioners. I am making a qualification here. 70 to 80% treated by qualified medical practitioner is all into public sector, not into private sector. Private sector doesn't even have that many beds as government system has. Government system has more than 1 lakh beds. Out of that, 70,000 are into medical colleges and district hospitals and sub-districts. While private sector has 45,000 or even lesser bed, and they always struggle to to fill them up. Here's this. I put a page paper ad here. So OPD per day in SS hospital is 10,000. It crosses 10,000. In divisional hospital, 7 to 8,000. In district hospital, 2 to 4,000. PHC, CHC also it is up to 300. Not PHC, sorry. PHC to are grossly underutilized. But CHC and district hospital, it is up to 300. It goes on. Next slide, please. So this and more patients are seen by private sector than public sector happening in Rajasthan. Next, please. Yeah. So I just put it this here that there is a private medical college in just previous level, which is providing all services across because their beds are empty and they run a medical college, and in order to showcase medical commission for keeping their registration intact, they are saying everything. In fact, even can you show the earlier please the one with the ad. So they are saying that even if you register 2 months in advance, then for delivery, we'll give you a private. Even that kind of offer is also made. So everything is free. They should delivery, and this is on the front page. And this is the Pacific Medical College and Hospital in Udaipur. And they are. It is the case in most of the hospitals, private hospitals in Rajasthan. Hardly people go and poor generally don't go to them even if they are enrolled under ABPMJ because Richa was writing or somebody else writing that it's only the middle based use social health insurance program. So next slide. So yeah. So now what are the challenges Rajasthan has? Acute shortage of human resource for health at all levels, especially of specialists, but not of otherwise. Problems of knowledge, skills and sensitivity among health providers ये बहुत बड़ा है knowledge का भी है skills का भी है sensitivity services of the
सॉरी अजय सिंगर जी प्लीज म्यूट पे प्लीज म्यूट पे साथियों प्लीज इसका ध्यान रख लीजिए ना थोड़ा सा अपने आप को म्यूट रख लीजिए थैंक यू थैंक्स
services of peripheral health institutions are utilized. It's very important. People, especially, qualified people, they prefer the others kind of things. As a result, we really don't know how much program led to reduction in out-of-pocket expenditure. So this is what these are the issues which we have with us. Next slide, please. Yeah. So any lesson for Rajasthan? Rajasthan has shown that it could come the tag of aspirational skill. Household consumption expenditure 2024 is high in Gujarat, Maharashtra, West Bengal, UP, Bihar, Odisha, Jharkhand, and Chhattisgarh. This is the latest of this monthly household consumption expenditure. High time for and high time for us to take complete charge concepting, planning, launching, and managing the health status of people or health services. My suggestion would be districts should become autonomous units for health planning and education with full administrative and financial power. That is what I'll argue for. And I can talk about why it is very important, etc. And this is the last slide, if you could show, please. Yeah. So the final lesson is only one common system of healthcare services for all and decision making applies to the lowest level. If there is one common system in the public, private, so that we have to keep discussing, talking, and what find out what they have now, what is, how to get it done. All of these things will be edited if we have one common system. But I know it's a different. I don't know that it's possible or not possible. So this is just I'm going to say. I think I finished within my time which was assigned to me. Thank you. Thank you very much for listening to me patiently.
Thanks very much, Narendra ji. I think that was an excellent presentation and quite a revelation in some sense because कभी भी हमने इकट्ठा करके राजस्थान के बारे में इस तरीके से नहीं सुना है उसके आंकड़ों के साथ. And some things I will point to in your presentation just quickly. And there were some questions in chat. Somebody wanted to know about the poster. He did explain the poster in English how a private medical college, because it's not getting enough admissions, has now declared that anybody who comes will get free services. So he was trying to explain with data earlier that the utilization of public health services is far greater than the private sector in Rajasthan. That was basically what that ad was kind of illustrating. Just some quick points from his presentation जो मुझे लगता है कि important to reiterate. माने काफी स्पष्ट था इनका पूरा प्रस्तुति और बहुत साफ तरीके से आंकड़े भी रखते हुए मतलब दिख रहा है कि राजस्थान में कुछ कुछ चीजें हो रही हैं. एक चीज जो नरेंद्र जी ने कहा मेरे ख्याल से उसकी गांठ हम लोगों को बांध लेनी चाहिए शुरू में ही, जिससे कि उस पर डिबेट ज्यादा की जरूरत शायद ना हो विद हिम, कि दिस इज अ मेडिकल केयर सिस्टम, मतलब हेल्थ नहीं मेडिकल केयर. सो मेनी पीपल से दैट अबाउट राजस्थान की राजस्थान में मेडिकल केयर सिस्टम पे बहुत काम हुआ है. So Narendra ji made it quite clear that he's whatever the state government calls it or whatever the terms are, but really we are talking about medical care. I think that's important to note. The other thing that was important to note was that there are no user fees. This is a very important distinguishing point between one state and another currently. And I think that if it holds true, and if he said that we don't know about out-of-pocket expenditures, but if that holds true, then that is something that is really something to note. He also clarified the questions that were raised in जैसे discuss earlier. जो सवाल उठा था कि अगर इंश्योरेंस है किसी के पास तो वो पब्लिक सेक्टर में जाके इंश्योरेंस क्यों यूज करेगा अगर यूजर फीस नहीं है. तो ही एक्सप्लेन कि लोगों के पास चॉइस नहीं होता है, वो हॉस्पिटल डिसाइड करता है कि वो कौन सी स्कीम उस इंसान पे लागू करेगा. ही एक्सप्लेन दैट. सो आई थिंक दैट अ लॉट हैज बिकम क्लियर एंड देयर इज रियली समथिंग here to talk about and discuss. And also I feel future work, future campaign, future investigation challenges also he talked about, the fact that we don't know what the out of pocket expenditure is. So there are researchers here who Indranil and others who work specifically on PMJY and other such schemes. And so this is a challenge for us to really look at what is happening on the ground with patients. So just 3-4 questions or clarifications I will take, and then we'll move to Jean. So if you could raise a hand, and I really request you बहुत हाथ जोड़ के कि देखिए अपने जो बोल नहीं रहे प्लीज म्यूट में रहिए, इसका थोड़ा ध्यान रख लीजिए क्योंकि कनेक्टिविटी बहुत खराब है, देख रहे हैं टेक्निकल बहुत चैलेंजेस हैं. उससे बहुत मतलब दिक्कत आ जा रही है। तो प्लीज़ थोड़ा सा आप लोग भी सहभाग करिए। और हाँ, तो सवाल अगर चैट पे भी पूछे जा सकते हैं नरेंद्र जी, चैट में टाइप करके जवाब दे देंगे। लेकिन अगर आप लोग वर्बली पूछना चाहें तो हाथ थोड़े खड़े कर दीजिए, तो मैं तीन चार जरूर लेना चाहूंगी। या मैं चैट से भी पूछ सकती हूँ अगर कोई हाथ नहीं उठा रहा है। तो एक सवाल आया है नरेंद्र जी की, अम, ये जो विकेंद्रीकरण की बात आप
जी
कर रहे
बोली थी नरेंद्र बोलो। हाँ हाँ।
हैं। हाँ
या
जी।
जी। मैं कहा
हाँ
जी लगाने की जरूरत नहीं है।
हाँ, वो जो ऑटोमेटिकली आ जाता है जबान पर कभी नरेंद्र कभी नरेंद्र जी। तो हाँ, तो ये पूछा गया है कि इसमें जो विकेंद्रीकरण की बात आपने कही थी, ये एक्चुअली है क्या, यथास्थिति में ये है क्या, और डिस्ट्रिक्ट कैसे इंडिपेंडेंट यूनिट बना है, राजस्थान में बना है कि नहीं बना है, वो मैं पूछ रही हूँ। और सवाल में पूछा गया कि कैसे डिस्ट्रिक्ट को इंडिपेंडेंट यूनिट बनाया गया। तो इस सवाल का यदि आप जवाब शुरू करते हैं तो मैं देखती हूँ और कौन से सवाल आ रहे हैं।
नहीं, कोई ऐसा अभी तक तो कुछ नहीं है। ये तो मेरा मतलब मैं बताऊं कि ऐसा होना चाहिए। पर ये जरूर हम कह सकते हैं कि किसी हद राजस्थान अपने स्तर पे काफी खड़ा हुआ है और अपने ढंग से सोच रहा है और अपने ढंग से काम कर रहा है। ये एक अपने आप में एक जरूर बात है। तो स्टेट लेवल पे काफी कुछ अपने स्तर पे होने लगा है, वो अब है। बाकी अब डिस्ट्रिक्ट तो है नहीं कुछ भी। डिस्ट्रिक्ट तो अभी कंप्लीटली डिपेंडेंट ऑन स्टेट्स, एंड स्टेट्स मोर और लेस डिपेंडेंट ऑन सेंटर, एंड मोर और लेस डिपेंडेंट ऑन, I would not say. So it's better. So this is what it is at the moment, but decentralization is needed. अभी हम लोगों ने एक कैंपेन यहाँ पे शुरू कर रहे हैं कि जहां जहां पर भी पोस्टें खाली हैं, पीएचसी पे मेडिकल ऑफिसर की पोस्ट खाली है, सब सेंटर पे नर्स एएनएम नहीं है, वहां नहीं है, तो वी आर राइटिंग पिटिशंस टू द डिस्ट्रिक्ट अथॉरिटीज एंड टू स्टेट अथॉरिटीज। ये
नरेंद्र जी की आवाज फिर गायब हो गई है, पर मुझे लगता है कि इस सवाल का जवाब तो स्पष्ट था। हम्म। तो नरेंद्र जी, आप फिर गायब हो गए हैं, लेकिन मैं कह रही थी कि सवाल का जवाब काफी स्पष्ट है कि विकेंद्रीकरण कुछ हुआ नहीं है। वो
नहीं।
हमारा हमारा आदर्श है और हम उस पे मतलब सुझाव दे रहे हैं। लेकिन ये जरूर हुआ है कि राज्य थोड़ा इंडिपेंडेंट हुआ है, मतलब द स्टेट इज डूइंग मच मोर एंड कंट्रीब्यूटिंग मच मोर। आई सस्पेक्ट दैट पर कैपिटा कंट्रीब्यूशन इन हेल्थ इज हायर इन राजस्थान एज compared to all India. Other people would be able to
राइट।
have more information on that. Veena is asking कि सारा डेटा डिजिटलाइज्ड है क्या? लास्ट दैट आई डिड दैट स्टडी इन राजस्थान नरेंद्र जी, डेटा तो था ही नहीं। कुछ डेटा अवेलेबल नहीं था बिल्कुल भी, मतलब सरकार के पास भी नहीं था, पब्लिक डोमेन तो छोड़ दीजिए। एंड दैट वाज वन ऑफ द स्ट्रॉन्ग पॉइंट्स वी मेड इन दैट रिपोर्ट, इन दैट स्टडी, कि डेटा इज नॉट अवेलेबल। सो आई जस्ट प्लीज रिस्पॉन्ड टू दैट।
वैसे ऐसा नहीं है, डेटा तो इनके पास होता है, पर ये somehow they don't really maintain it the manner they could share it. That is what generally is. तो वो काफी कुछ रॉ जैसे ही पड़ा रहता है, तो if you ask them to give this particular figure, they will not be able to provide that figure. But few things are there. जैसे मैं अभी बता रहा हूँ, ये यहाँ की जो प्रिंसिपल हेल्थ सेक्रेटरी हैं, she could so very convincingly tell that how many patients we treat every day, and how much money we spend every day under this scheme of MA and APMJ. So those kind of things they have, and when it comes to make provide data, they do provide data. So है data. और इफ यू गो ऑन द एनुअल रिपोर्ट, जो एनुअल रिपोर्ट है डिपार्टमेंट ऑफ मेडिकल हेल्थ गवर्नमेंट ऑफ राजस्थान की, इट इज अवेलेबल ऑन द वेबसाइट, आई कैन गिव द लिंक. Lot of information is there in there, but then department also made one presentation somewhere with Ayawad. So she has that big presentation of the government of Rajasthan where they provide all kind of details and tweeted, and the trend analysis also.
अ, वंदना जी, मैं क्वेश्चन पूछना चाह रहा था, मुझे वो हाथ वाला मेरे दिखा नहीं थे।
कोई
कैन आई
नहीं
आस्क?
जयपाल जी, आप पूछिए अपना सवाल, उसके बाद
ओके।
अक्षय का एक सवाल चैट में है, वो मैं डाल दूंगी। आप पूछिए। हम्म।
या तो नरेंद्र, मैं ये पूछना चाह रहा था, एक्चुअली जब हम लोग फील्ड में जाते हैं, गांव में जाते हैं, तो बहुत सारे लोग ऐसे मिलते हैं जो, और खासकर साउथ राजस्थान में, जो हेल्थ एक्सपेंडिचर की वजह से इंडेटेड हैं, और मतलब बहुत ज्यादा इंडेटेड है, और मेन रीजन जो है हेल्थ एक्सपेंडिचर है। और जो आपके प्रेजेंटेशन से लग रहा है कि भाई काफी सारी चीजें फ्री हैं, तो ये क्या कारण है, क्या मतलब ये फैक्ट है, या इस पे कोई स्टडीज हैं, कितने के लोग एक्सक्लूडेड हैं? वो बहुत सारे कारण बताते हैं, और अभी भी गुजरात में और प्राइवेट में ट्रीट कराने जाते हैं। और जब उनसे पूछा गया कि भाई सब कुछ फ्री है, वो कह रहे हैं कि साहब, कहने को फ्री है, वहां तो हमें घुसने ही नहीं देते हैं, वहां तो कुछ मिलता ही नहीं है। एक तो ये है। दूसरा इसी से रिलेटेड मैं सोच रहा था कि ये जहाँ जहाँ भी हेल्थ को इंश्योरेंस से लिंक किया है, चाहे दूसरे कंट्रीज का एग्जांपल ले लीजिए, द कॉस्ट ऑफ हेल्थ सर्विसेज हैव इंक्रीज मैनीफोल्ड, and major reason is the fraud happening there. A lot of people who may not be sick, but they, I don't know how they find it, but they somehow get the money, or the insurance companies then no again put pressure on government to increase cost of the health services. तो ऐसा कुछ कंपैरिजन हो सकता है कि जहां पर, या हेल्थ इंश्योरेंस को कुछ इस तरह से डिजाइन किया जा सकता है जहां पर लार्जर से पेशेंट का हो, पब्लिक का हो, रादर देन बिटवीन गवर्नमेंट एंड इंश्योरेंस कंपनी। ये दो चीजें मैं पूछना चाह रहा था। इफ यू हैव एनी कमेंट ऑन इट, थैंक यू सो मच,
धन्यवाद। हाँ,
बट
ये
योर प्रेजेंटेशन
हाँ,
वाज वेरी गुड।
मैं कुछ
धन्यवाद।
बोलूं?
ये सवाल जो जमीनी सवाल है उसमें मैं एक और भी जोड़ दूं कि ये मतलब हमने जमीन में ये भी मतलब कई चीजें, एक तो कि सच में फ्री है कि नहीं, दूसरा कि जो फ्रॉड वाला मामला है इसमें ये भी होता है कि बहुत गरीब इंसान अपने इंश्योरेंस मतलब एक तरीके से बेच देता है कि चलो 10% उसी को मिल जाता है और फिर बाकी इधर उधर भी बढ़ जाता है। जैसे राशन में होता है ना कि भाई इधर उधर बांट दिया जा रहा है, और या किसी भी कैश बेनिफिट में ये होता है कि थोड़ा तू ले ले, थोड़ा मैं ले लेता हूँ, और उस तरीके से उसका इंश्योरेंस खत्म हो जाता है। ये भी देखा जा रहा है। तो ये सब जमीनी यथास्थितियां हैं जो धन्यवाद करना चाहूंगी जयपाल सिंह जी का कि उन्होंने उसको उबारा है। नरेंद्र जी, इसका जवाब यदि आप दें तो एक दो सवाल चैट पे और भी हैं। हाँ, बोलिए।
तो देखिए, ऐसा है कि इंश्योरेंस से नेचुरली जो पेशेंट है उनकी तो बढ़ेगी अनडाउटेडली, और स्पेशली इंश्योरेंस का फायदा गरीब व्यक्ति तो इतना ज्यादा प्राइवेट में नहीं उठा पाता है। सरकारी में तो वो, हम यहाँ तो राजस्थान में तो वो उठा ही लेगा, क्योंकि वो सब कुछ फ्री है, चाहे वो इंश्योरेंस में चाहे ना हो। पर प्राइवेट में डॉक्टर्स, जो प्राइवेट हॉस्पिटल्स हैं, वो गरीब को तो ये कह के ही कहते हैं कि भैया ये आपका जो बीमा पैकेज में है नहीं, जो पैकेज में हमारे लिए इंश्योरेंस में जो है हमारे, तो इस कारण से उनको तो बहुत ज्यादा मिलता नहीं। बट प्राइवेट जो वो जो मिडिल क्लास, लोअर मिडिल, थोड़े स्मार्ट लोग हैं, वो इसका पूरा फायदा उठाते हैं। तो नंबर ऑफ पेशेंट्स तो डेफिनेटली इंक्रीज होते हैं, पर पुअर रियली गेट बेनिफिटेड इंश्योरेंस स्कीम, आई रियली नॉट श्योर। मे बी सम, बट मे नॉट बी सम, और वो दे एंड अप पेइंग डबल। मतलब वो अपनी जेब से भी चला जाता है, सरकार का भी चला जाता है उसमें, तो समटाइम दैट आल्सो हैपेंस।
जी, एक सवाल जो अक्षय ने पूछा, वो आई मीन एंड अक्षय हैज बीन फीडिंग इनटू द कॉन्वर्सेशन ऑन जे से डिस्कस आल्सो, कि इसमें राजस्थान व्हाई डिड दे फील द नीड टू गो इन विद एन इंश्योरेंस कंपनी, सारा का सारा ट्रस्ट में क्यों नहीं कर दिया था? तो इसका क्या हमको क्या समझ में आ रहा था नरेंद्र जी?
तो देखिए, मैं तो अभी तक मेरा ये मानना है, और ज्यादातर मैंने काफी जानकारी आपका की इसके बारे में, तो इंश्योरेंस का सिस्टम
आपकी आवाज फिर टूट रही है।
इन्वॉल्व।
नहीं सुनी। हाँ।
अच्छा।
हम्म।
हाँ, इंटरनेट कनेक्शन इज अनस्टेबल। अब आओगे?
थोड़ा माइक के भी पास रहने से शायद फायदा हो। हाँ, बोलिएगा, बोलिए।
हाँ, तो बस यही अ,
नहीं, हम नहीं सुन पाए हैं। या तो आप उसको चैट पे ही जवाब दे दीजिए, मैं उसको पढ़ के सुना दूंगी, आप टाइप कर दीजिएगा। एक और हाथ, आई थिंक आई सॉ।
पार्टिसिपेट।
हाँ नरेंद्र जी, आपकी आवाज़ आ रही जा रही, चैट पे डाल दीजिए इसका जवाब। और आपकी, हाँ, अमूल्य, आपका हाथ उठा था, क्या आप कुछ कहना चाह रहे थे?
जी।
हाँ,
अ,
पूछिए।
जी नरेंद्र जी, बस मेरा दो सवाल ये था कि क्या, क्योंकि कल भी मैं एक ट्रेनिंग में था, उसमें काफ़ी चर्चा हुई कि क्या हम ये मान लें कि इंश्योरेंस मॉडल जो है वो अच्छा चल रहा है और उसी में कुछ सुधार करके अलग अलग जगह कुछ कुछ कमिटीज़ बनी है इंश्योरेंस की, और उसी में कुछ सुधार करके हम हेल्थ सिस्टम के स्ट्रेंथन करने की बात करें, या फिर हम बोले कि नहीं, हेल्थ सिस्टम हमारा एक पुराना डिमांड है कि हेल्थ सिस्टम को स्ट्रेंथन करना है और यूजर फी ना लगे कहीं भी, क्योंकि अभी राजस्थान भी अभी डायग्नोस्टिक में यूजर फी पीपीपी मॉडल लाने की बात चल रही है। और दूसरा मेरा यह सवाल था कि जब हम डिसेंट्रलाइज की बात कर रहे हैं, तो मध्य प्रदेश सरकार में एक आर्गूमेंट चल रहा है ये कि डिस्ट्रिक्ट को हम सेल्फ फाइनेंस कर दें, जैसे मेडिकल कॉलेज को सेल्फ फाइनेंस कर दें, और डिस्ट्रिक्ट अपने हॉस्पिटल का पैसा जैसे रोगी कल्याण समिति रेज करती है वैसे रेज करे, और उसमें पीपीपी मॉडल प्राइवेटाइज करे और उसमें मेडिकल कॉलेज डेवलप करे, और वो अपनी ज़मीन से भी पैसा अर्न करे। तो उसमें ये रिस्क भी है, तो उसको आप कैसे देखते हैं?
Discussion and debate. So, Narendra ji, yeah. I think if you're still not, your connectivity is not good, I will move, but I'll just give you one chance to, yeah.
नहीं, मैंने सुना ही नहीं इनका प्रश्न, तो मुझे पता नहीं एग्जैक्टली।
हाँ, इन्होंने पूछा एक तो ये कि आपका मतलब योर व्हाट इज योर नेट अंडरस्टैंडिंग कि इंश्योरेंस स्कीम्स आर हेल्पफुल एंड वी शुड ट्राई टू रिफॉर्म दोज एंड मेक देम बेटर, और शुड वी raise the demand for user for the abolishment of user fees. I mean, they're not necessarily contradictory. That is one thing. And the other question was कि districts, there's some conversation happening about making districts self-sufficient in some sense, and asking them to raise funds through PPP modes and so on, जैसे कि मेडिकल कॉलेज के साथ किया गया है कि कुछ पैसा दे दिया जाए डिस्ट्रिक्ट में, लेकिन ओवरऑल उनको बोल दिया जाए कि भाई आप अपना करिए, अपना रेज करिए और अपने तरीके से करिए, मतलब डिसेंट्रलाइजेशन इन दैट मोड। तो इस पे आपकी कोई राय अगर है तो, एंड
हाँ
क्विकली
हाँ
बिकॉज़ वील मूव टू जो आफ्टर दिस, या।
हाँ हाँ, डेफिनेटली डेफिनेटली। देखिए, इंश्योरेंस को तब रखनी
नरेंद्र जी ये नहीं कमेंट हो रहा
कॉन्ट्रडिक्शंस।
है, हाँ। आई सजेस्ट कि आप इन सवालों का, ये चैट बॉक्स पे आ चुके हैं ये सवाल, अक्षय का भी सवाल कि क्यों हम ट्रस्ट में ही क्यों ना जाएं और इंश्योरेंस कंपनी को। आपकी आवाज नहीं आ रही है तो आप चैट में ही डालिए इसका जवाब। हाँ, चैट बॉक्स में टाइप कर दीजिए, और अमूल्य का भी जो सवाल है, दो सवाल है, उसका भी चैट बॉक्स पे डाल दीजिए। वो चैट पे आएगा तो मैं
हाँ हाँ,
सुना दूंगी सबको, है ना?
ओके ओके ओके।
Okay, I think we move to Jean. So welcome, Jean. I mean, you've heard a lot of the context that's happening. I mean, the discussions that are happening around with all of us, the confusions, the dilemmas, and so over to you to now speak to us in greater maybe depth and detail on this front. So yeah, over to you.
Thank you, Vandana. Thank you for inviting me to participate in this very important event. There was a lot of very interesting discussion in recent weeks on the JSA Google groups about some of the issues that we've already discussed. So it's good to see that this being taken forward. And I'm also hoping that it will ultimately lead to some action, because to me, the most important point that came out of Narendra's presentation is how healthcare has become a political issue in Rajasthan. And he was too modest to mention that this happened largely through public mobilization and campaigns, of which he and many others have been part. And this has to happen, I think, all over the country. And it is happening to some extent in some places, but we need a lot more than that. I am not an expert at all on health insurance. In fact, I have many more questions than answers. So all I can do is to share some of these questions by way of opening the discussion. I did write one article on health insurance with a colleague called Anfaz Abdul Wahab, who is here, I think, although he may not be able to contribute because I think he's in another meeting as well. The article is called How Healthy is Health Insurance? And the main purpose of this article was, first of all, to draw attention to the runaway growth of health insurance schemes in India, not just PMJY, but now all the states have their own health insurance schemes as well. And expenditure on these schemes is growing very fast and to some extent displacing other important healthcare expenditure. And the other point we tried to make is that there's a kind of dilemma in all this. And the dilemma is that on the one hand, India's health insurance schemes provide, or at least can provide, some relief to poor patients when public health facilities are inadequate due to decades of dismal low investment in healthcare. But on the other hand, these schemes are quite a mess, as I will try to explain later. This is something that perhaps didn't come too much in Narendra's presentation. Of course, it may be better in Rajasthan. Not only are they a mess, but even if they were not a mess, they reinforce the dependence of the health system on profit-driven healthcare. I think that is a big issue. Now, of course, over time, we can deal with this dilemma by much more investment in public health facilities, and India should certainly do that, but that will take time. And so what do we do in the meantime? For example, what do we do with the 70% of cancer patients for whom there is no capacity in the public sector? Do we leave them to their own devices, knowing that many of them cannot afford to pay for private healthcare? Or do we try to help them to access private healthcare through some of these health insurance schemes? That's the basic dilemma. I will come back to this at the end, but before that, let me say a little more about how these health insurance schemes work and should work. Before that, I want to make one general point, which is that as an economist, and I'm saying as an economist, not just as an activist, I'm quite opposed, in fact, very opposed to profit-driven healthcare. The profit motive, in my view, doesn't belong at all in healthcare. And the main reason why the profit motive is toxic in healthcare is that the patient is a sitting duck. And this opens the door to exploitation. I think all of you know that. I don't have to explain it. This was explained quite well 60 years ago by a very famous economist, Kenneth Arrow, in an article on medical care, where he explained that the relation between patient and doctor or nurse is based on trust, because the patient has no idea what their disease is, what kind of treatment they require, what kind of medicines they require, and so on. And so all you can do is trust the doctor or the nurse. And the profit motive basically destroys that trust, because if you suspect the doctor of trying to make money from you and not trying to help you, then obviously you have no reason to trust that person. Now, this doesn't mean that there's no role for private initiative in health, but it means that the private initiative should be mainly non-profit. And the non-profit private sector is indeed very important in many countries around the world. The private non-profit sector in India is very small, but in many other countries it's quite important. There are all kinds of private institutions, non-profit institutions like NGOs, churches, trade unions, universities, and so on, that run health centers. And I don't think there's anything wrong with that. In fact, it can be a very good thing. So the important thing, I think, in healthcare is the important distinction is not between private and public, it's between profit and non-profit. Now, the idea that you could free the healthcare system from the profit motive may seem utopian. We know for a fact that it is possible. One way to do it is to organize healthcare as a universal public service. That is the idea of the National Health Service in Britain. And it's also, by and large, how things work in a number of other countries, not many countries, but quite a few, including Scandinavian countries, Italy, Spain, in the developing world, Cuba, of course, a very important example, and closer to India, Sri Lanka. In many of these countries, including Britain, there are, of course, moves nowadays towards some form of privatization, but the basic principle of healthcare as a universal public service remains. And these health systems are among the best in the world, not only most effective and equitable, but also very cost effective. So I have no doubt that ultimately this is the best model for all countries, including India. Now, this does not mean that the NHS model, if you like, is the only way to achieve universal healthcare. Yeah, universal healthcare in the sense of everyone having access to quality healthcare, irrespective of their ability to pay, which is the basic principle underlying the National Health Service, and the notion of universal healthcare that also appears in the Bore Committee report in India. Many countries have achieved something like universal healthcare in that sense, based on a combination of public service and social insurance. For example, Canada, many countries in Europe, Japan, and closer to us, Thailand. That may appear to suggest that social insurance can also contribute to universal healthcare in India. However, it is important to understand that these social insurance systems are quite different from India's health insurance schemes. In particular, like the National Health Service, they are relatively free of the profit motive. This brings me to the distinction between commercial health insurance and social health insurance, which I think is very important. And quite often in the debates that we have on health insurance, we don't pay enough attention to that distinction. So at this point, I'll try to share my screen. I hope it works. Okay, can you see the slide?
Not yet, but it takes a little. Yeah, now we see it.
Okay, so one important illustration of the contrast between commercial and social insurance is the contrast between United States and Canada. United States has a health insurance system basically on commercial lines. The healthcare system itself is largely a commercial system, and the results, as you all know, are quite disastrous, if not catastrophic. Canada is a good example of an effective social health insurance system. It has all the characteristics that I've listed here. United States has none. One can add further features of a good social insurance system when one can talk about price control, referral systems, and so on. But I have listed here 4 or 5 features which appear to me to be important for any credible social insurance system. The first and most important one, of course, is that the system should be geared to public interest and not to profit. And that, of course, determines a lot of other things. In particular, it would mean, since we have talked about earlier about this question of why an insurance company is involved, the system should not be run by a profit-seeking insurance company. And most states, by the way, in India today, are no longer using private insurance companies. Funded from general taxation, not from insurance premiums. Enrollment should be universal. I've put compulsory in brackets. The important thing is universal, but compulsory can be important to achieve universality. So in Canada, province-wise, everyone is compulsorily part of a common universal and compulsory insurance fund. Compulsion may be required for the same reason that if you want everyone to wear a helmet, you may have to make it compulsory. Everyone knows it's a good thing to wear a helmet, but not everybody does it. And it's the same with health insurance. We all know it may be useful, but that doesn't mean that we do it. All facilities have to be in the network. This can be important. This can be particularly useful to have what is called a single payer system, but I'm not going to go into that. And last but not least, very important, a focus on non-profit providers, public health facilities and private non-profit. So in Canada and in all the countries I've mentioned as having an effective social insurance system, most of the healthcare facilities, whether they are public or private, are non-profit. Now, in India, we have some of these features and not others. The first two we have. When I say India, what I mean is PMJAY, the Pradhan Mantri Jan Arogya Yojana, and now the state schemes, which we call SHIPs, state health insurance programs, in the article I mentioned earlier. So all these schemes have the first two features. To some extent, the third feature exists in some states. According to Naren, the health insurance system in Rajasthan is as good as universal. I think it's also true in 1 or 2 other states. So that is beginning to happen, but mostly it's still very far from universal in most states. And then the last two characteristics we don't have, and in particular, none of the Indian health insurance schemes focus mainly on non-profit providers. I think that you're all familiar with PMJAY and what we call the SHIPs, the state health insurance programs like Chiranjeevi and so on. But for those who are not familiar, I'll very quickly remind you of how it works and present a few basic statistics. So basically the way it works is that these are mostly targeted schemes, so there's an eligible population. So for example, in Jharkhand, it would mean mostly anyone who has a ration card. So if you belong to that eligible population, you can get a health insurance card like the Ayushman card in the case of PMJY. And if you fall ill, you can go to any hospital of your choice among the empaneled hospitals. Empaneled hospitals would include public as well as some private hospitals. All this is hospital-based. All the health insurance schemes in India, at least all the SHIPs and the PMJY, so far as I know, are all based on inpatient hospital care. Vandana has already drawn attention to that important point, but I'm just repeating it. So you can go to any hospital, and then the hospital cannot refuse to take you as a patient, at least in theory. In practice, of course, it may be something else. And then you're supposed to get treatment for free, and the insurance fund repays the hospital directly based on prescribed rates for different procedures. So that's basically how it works. Between PMJY and the state schemes, officially more than 80% of the population is covered. This is not reflected, however, in household surveys. If I have time, I'll explain that a little more later. But the coverage is definitely quite large and growing. The budget, PMJY is 12,000 if you include the state share of 40%, which is a fair amount. You might say that it's not a lot to cover 40% of India's huge population with a cover of 5 lakh rupees per household per year. But the reason why it's so low is that many patients actually are not using or not able to use their health insurance. Vandana has already made that point, and I'll come back to it. So there's nothing impressive at all in the fact that you're able to cover so many people with so little money. The empaneled hospitals are more or less 50-50 public and private, but most of the expenditure, as you can see from the last row, about 2/3 of the expenditure goes to the private hospitals, which mostly means private for-profit hospitals, and I think that's where there is a problem. Now, I'll skip this slide. We can come back to it later, maybe. Let me explain what I see as the main problems with these health insurance schemes. Firstly, two problems that appear to me to be related to the lack of universality. When you don't have universal coverage, then there is discrimination between the insured and uninsured patients. This problem takes a different form in the private sector and the public sector. In the private sector, the form it takes is underutilization and denial of insured care. And the reason is very simple, that in the private sector, the hospital always prefers an uninsured patient to an insured patient. And therefore, they always have an incentive to prevent the patient in one way or another from using their insurance. If somebody comes to them with an Ayushman card, they can very easily try to persuade the patient that their disease is not covered under the scheme, or there's a technical problem with Aadhaar or whatever it is. And that is, I think, the main reason why the utilization of these schemes is so low. According to a recent analysis of the latest National Sample Survey around the 2022-23 Household Consumer Expenditure Survey by Sundar, who is here, I think, and his colleagues, only 35% of people who had been hospitalized in the reference year with an insurance were able to use their insurance, 1/3. And actually, I believe it's less than that, because that survey, according to me, vastly underestimates the number of people who are insured. So the proportion of insured people who are able to use their insurance when they when they are admitted in a hospital, maybe even much less than 35%. Okay, so that's the private sector. In the public sector, it's the opposite problem. The public hospital always prefers an insured patient to an uninsured patient, because an insured patient brings money. If you treat an insured patient, the insurance fund will give some money to the hospital. And that brings some issues that are discussed, for example, in Raja Lakshmi's recent report that she shared on the GSA Google group, where the patients, instead of being treated, are put under pressure to enroll for insurance, or there's special facilities for insured patients and so on, the kind of thing that we really wouldn't want to see in public hospitals. Now, these two problems, in principle, you could deal with by universalizing. But even if you universalize, there are still a whole lot of problems related to the fact that these schemes don't focus on the non-profit sector. First of all, is an overarching conflict between the profit motive and the interest of the patient. For example, if you have a fractured leg, you go to a private hospital, you may not need anything more than a plaster, but if the private hospital can make money by operating you, they might do it. And we know that this kind of thing is happening in and out. Now, this conflict is supposed to be resolved by a host of monitoring measures, digital surveillance, reports, photographs, calling the patient after the event, blah, blah, blah. There's a whole array of audit reports in particular. But I'm very skeptical of this actually working. There's no evidence that it works. In fact, there's a lot of evidence that it doesn't work. For example, we know for a fact that most patients who use their insurance in the private sector end up paying a lot of money. Maybe less than they would otherwise, but they do pay money. And that's a violation of the rules. So it means the monitoring system is not doing what it's supposed to do. Okay, now even if you resolve that conflict, even suppose that this monitoring and surveillance system actually works, you still have a big problem of subsidizing a bloated for-profit sector and subsidizing hospitalization at the expense of primary healthcare. And finally, and this is the elephant in the room, that's why there's an elephant at the bottom of this slide, a huge vulnerability to fraud and abuse. Inflated bills, fake claims, unnecessary procedures, patient being charged. We know it's happening. We know all this is happening. What we don't know very clearly, unfortunately, is to what extent it's happening. Is it so bad that these schemes are worse than nothing? Can these problems be resolved? There's information on all this. There are bits and pieces, there are studies here and there, but overall, we don't know very much. We don't even know how many people are insured. As I mentioned earlier, according to the official coverage figures, it's more than 80%, but this is not at all reflected in survey data. In the NFHS, the latest NFHS, 41% of households have at least one member insured. And according to the latest NSS, which is more recent, only 25%. So the figures are all over the place. So there's a gaping knowledge gap here and a need for much more information, not just formal surveys, but also things like public hearings and so on and so forth, in which some of us could also perhaps play a role. So all this brings us back to what I call the dilemma of insurance. On the one hand, it does provide some short-term relief to poor patients, or at least it can do it. But on the other hand, it's a bit of a mess. And these schemes, as they are today, reinforce the grip of the profit-driven healthcare sector. Question is, what do we do? Where do we go from there? Vandana has raised that question. And as she said, it's not easy to say what can be done. I have some thoughts on that, but I think I'll leave them for the discussion because it would be good to have plenty of time for discussion. I will just say that to the extent that these schemes are going to stay, and I think, like it or not, they are likely to stay. I think if they're going to stay, then the thing to do is to try to bring them closer to a proper social insurance system, including universalizing them, which Rajasthan, according to Naren, has already done de facto, and very importantly, trying to focus them more on the non-profit sector. And one way of doing that, which seems to be used to some extent in Karnataka, this is what Prasanna told me, and perhaps he can tell us more about that, is to say that patients have to come through the public sector, and then the public sector might refer them to the private sector if there is no capacity, and only if there's no capacity in the public sector, preferably the non-profit sector, if possible, and the profit sector would be the last resort. If that's how it's organized, then over time, as the public facilities expand, you could hope that the private profit sector will actually shrink instead of expanding, as it is already, according to Naren, happening to some extent in Rajasthan. Okay, so I'll stop here because I would really like to have plenty of time for discussion and comments from others, but we can certainly talk more about some of these aspects if you like. Thank you.
Thank you so much, John. I think that was a very, very important presentation. Very significant points were made. मैं थोड़ा सा हिंदी में ज़रूर अनुवाद करना चाहूँगी क्योंकि कुछ लोग यहाँ पे हैं जो कि जिनको शायद थोड़ी सी कठिनाई हो सकती है और उसी के साथ साथ मतलब जो महत्वपूर्ण बिंदु जॉन ने उठाए हैं उनको भी मैं साथ साथ दोहराने की कोशिश करती हूँ। तो एक चीज़ जो उन्होंने कही मुझे लगता है कि बहुत बहुत इम्पोर्टेंट है और वो नरेंद्र जी ने उसका कॉन्टेक्स्ट नहीं दिया कि ये सब हुआ कैसे, मतलब अगर राजस्थान कुछ अलग कर रहा है तो ऐसा क्यों हुआ। जॉ पॉइंटेड टू दैट क्वाइट क्लियरली कि राजस्थान में एक पॉलिटिकल प्रोसेस रहा है जहाँ पे स्वास्थ्य एक मुद्दा बन पाया है और उसमें सारे ही अभियानों की बहुत भूमिका रही है और वो बहुत महत्वपूर्ण है और उसके बिना शायद ये सब कुछ जो हम राजस्थान में जो अच्छा देख रहे हैं जो जिसमें भी मतलब अच्छा का मतलब ये नहीं है कि ज़मीनी कोई उसमें कॉम्प्लेक्सिटीज या चैलेंजेस नहीं है, लेकिन जो कुछ भी दिखाई पड़ रहा है जो कि दूसरे राज्यों के बनस्पत थोड़ा अच्छा चल रहा है वो उसके कारण से हुआ है। आई थिंक दिस इज समथिंग दैट ऑब्वियसली we know this, but I think it's very important to continuously remind ourselves that it's not does not happen without a political struggle and without participation, without making health an issue. स्वास्थ्य को एक मुद्दा बनाना। दूसरा उन्होंने जो एक उन्होंने कई चीजें कई बिंदु रेखांकित किए जैसे कि मुद्दा प्राइवेट और पब्लिक वाला उतना नहीं है उनके हिसाब से, रादर द इशू इज वेदर फॉर प्रॉफिट और नॉट फॉर प्रॉफिट। एंड ये आई थिंक यहाँ कोई नहीं होगा जो कि इससे इससे इत्तेफाक नहीं रखेगा कि हेल्थ इज नॉट समथिंग टू अर्न प्रॉफिट फ्रॉम। मतलब स्वास्थ्य से कभी भी हमको मुनाफा अगर कमाने की कोशिश कोई भी करता है तो वो जो सिस्टम है तंत्र है वो गड़बड़ ही हो सकता है, उसमें कुछ अच्छा नहीं हो सकता। तो ये बहुत जोरदार तरीके से जॉन ने और अपने सारे प्रेजेंटेशन में इसको कहते रहे हैं कि अगर सोशल हेल्थ इंश्योरेंस भी उस दायरे में हो या उस परिप्रेक्ष्य में हो, उस कॉन्टेक्स्ट में हो जहाँ पे फैसिलिटीज कैन नॉट रन हेल्थ फॉर प्रॉफिट, then it will obviously work much better than it does where there is a profit making motive. तो ये प्रॉफिट और नॉन प्रॉफिट ये उनके हिसाब से एक मुख्य बिंदु है। तो ये उन्होंने अपने सारी स्लाइड्स में भी बताया और उन्होंने बताया कि कैसे कुछ कुछ देशों में अलग तरीके से ये हो रहा है, लेकिन जहां भी हो रहा है वहां पे ये प्रॉफिट नॉन प्रॉफिट या तो सरकार खुद अपनी सेवाएं चला रही है, यूके का उदाहरण दिया, क्यूबा और यहाँ श्रीलंका का उदाहरण दिया, या फिर जो प्राइवेट सेक्टर इन्वॉल्व है वो नॉट फॉर प्रॉफिट प्राइवेट सेक्टर, इसमें कनाडा का इन्होंने उदाहरण दिया, थाईलैंड जापान का उदाहरण दिया। फिर आपने बहुत हाँ प्लीज जी आप अपने आप को म्यूट कर दीजिए, सचर म्यूट कर दीजिए। हाँ तो मुख्य यही था, मतलब उसमें बहुत सा डिटेल इन्होंने दिया, आंकड़े दिखाए। ये भी मतलब एक आंकड़ा जो मुझे लगता है कि वो मेरे दिमाग में बैठा कि इंश्योर्ड का 1/3 ही इंश्योरेंस यूज कर पा रहा है, जिनके पास है भी। पहली बात तो किसको है भी, और फिर जिनको है भी वो नहीं यूज कर पा रहे हैं, और जिन्होंने यूज भी किया है वो कितना खर्च कर रहे हैं उसके ऊपर, उस पर कुछ स्टडीज हैं। हम पीएचआरएस में भी, पीएचआरएन ने भी कुछ स्टडीज की हैं, माइक्रो स्टडीज हैं कि भाई आप इंश्योरेंस भी यूज कर लिया और उसके ऊपर भी आपको पैसा खर्च करना पड़ा। तो ये सब चीजें उन्होंने उल्लेखित की। मैं अब खुली चर्चा में जानना चाहूंगी क्योंकि मुझे लगता है कि मुद्दे काफी साफ हैं हमारे सामने एंड एवरीबडी एग्रीज कि द वे आउट इज नॉट इजी, क्योंकि कुछ लोगों को कुछ फायदा तो मिल ही रहा है, साथ साथ एक फॉर प्रॉफिट बहुत ही बड़ा सेक्टर हमारे देश में है। राजस्थान एक कुछ उदाहरण दे रहा है, लेकिन वो क्यों दे रहा है वो जरूरी है कि भाई सेम थिंग व्हेन अप्लाइड टू अ स्टेट वेयर देयर इज नो पब्लिक कंसर्न कि लोगों के स्वास्थ्य क्या हो रहा है, it obviously will not work. मतलब Rajasthan has done both things. It has invested in its public health system simultaneously to expanding a universal coverage of social health insurance. This is by no means happening all over the country. This investment in the public health system we are not seeing, and the universalization of coverage also we're not seeing. But Rajasthan has achieved the universalization by a personal premium. I mean that is the, I'm just repeating it, 850 per family, which is not a huge amount, but that is, these are the things that have happened. And I will also just recall what Narendra ji said ki OPDs are also covered and free. So it's not just inpatient, but it is also OPDs, but it is medical. It's not health. None of this is health. So this point Jean also made. So now I'm opening the floor. it will be better if we put hands up. And Jean doesn't seem to have a problem with connectivity, तो Jean की आवाज़ स्पष्ट आ रही है, तो हम लोग अलाउ करेंगे कि आप लोग अपने सवाल खुद ही पूछ लें और वो जवाब दे दें. तो अगर कोई हाथ उठाना चाहे तो मैं देख लेती हूँ. आई एम श्योर यू ऑल एग्री कि बहुत इंटरेस्टिंग है ये डिस्कशन और बहुत रिचनेस इसमें हमको मिल रही है. दोनों ही प्रस्तुतियों से एक जगह में बहुत सी चीज़ें आ रही हैं, इकट्ठा हम लोग बातचीत कर पा रहे हैं. इट्स फैंटास्टिक. एंड आई थिंक पर या इससे क्या निकलेगा वो एक अलग बात है. हाँ,
Then I was hoping that Prasanna would say something about the Karnataka system of referral.
श्योर. प्रसन्ना, कैन आई इनवाइट यू? या
Yeah, hi. Yeah, so Karnataka has this gatekeeping function. It is also sorry, am I audible? Yeah.
Yes.
So Karnataka has this gatekeeping function. It is also what you call identified a list of treatments and conditions which have to be given only at the public facilities. So there are various lists: 2A, 2B, 3B, 3C, and those sorts of things. I can share that paper. I just shared it with John. But of course, the quality of the paper is bad, but the process can be understood better. So they also have now, earlier it used to be a manual referral system. And as we know, in manual referral system, we have lost to follow up. So they have now made it an online referral system. So any person, non-emergency, they had to present themselves to a public facility, and then the public facility, if it has the, I mean, if those conditions are being treated, I mean, has the capability to be treated by the public facility, it will treat. Otherwise, it will refer to a private facility. And there is also a, I mean, it is claimed, we have not yet checked on the ground. They say that 50 facilities lists are given to people in their vicinity, and they have the choice, so that there is no specific gaming happening about the a particular private facility being favored and preferred and those sorts of things. So that is the more or less. And we also did the study in Karnataka, in which we saw that 50% of the money from PMJAY is going to public facilities. So one of the things we have to think about, and this is also answering to some extent Swati's question, is that the money maximum comes from union government. About 75% or 60 to 75% is the range that the union government supports the Ayushman Bharat or this publicly funded health insurance. And that makes the states to also say, okay, let us bring this, and then also see to it that the public facilities get some money from the union government coffers and those sorts of things. So that is one thing we have to keep in mind. And this was done first by Tamil Nadu when it cleverly used the earlier, I'm forgetting the earlier name of the insurance scheme. Yeah, when they use that to strengthen the public health facilities. So, I mean, whether the public health facilities get strengthened, whether that's the truth, whether that's the what you call fact. Yeah, these are all questions that we can ask, but the intent is that. So that's what I wanted to just.
Thank you, Prasanna. There's a very rich discussion happening on chat, which is there's too much text. मैं उसको पढ़ नहीं पाऊंगी, and perhaps we'll have to leave it there. There are various hands up. Jean, I'll come to you later. I'll just take a couple more comments and questions, as I will go to Anant after that to Purendra. Anant, please.
Hello. Actually, I had sent 2 points in the earlier round on the chat box also. Maybe they were missed. But my overall point is universal healthcare, as we have learned from our Almata days or Janaswastha Abhiyan days, is basically both primary healthcare, secondary and tertiary. And even in Rajasthan, I don't think we are anywhere near universal healthcare as we understand it by primary, secondary, tertiary. As we all know that all the government insurance schemes, even if they are non-profit and paid by the government, basically for hospitalized patients, even that is true. Also for a few certain list of procedures, some 1400 procedures or somewhere here and there, at least in major part. And all this accounts probably not more than 10% of the total patients in the society. So all the health insurance scheme, even if they're paid by the state government, they do not cater to more than 10%. Most of the patients are IPD, are outpatient patients. Now in Rajasthan, very good that the proportion of people attending the OPD in public health facilities is almost 70%, as Narendra has said. I had to locate that figure or those kinds of figures in the public domain, but I could not get any such figure of 70% OPD cases being treated in public hospitals. So I would request Narendra to send the original source of the data from where he's talking about. So my first point is OPD, IPD cases is not equal to universal health coverage. And private sector, even if it is just, let's say 30%, again, all that has to be corroborated. The claim that private sector only caters to 30% of the patients, even in urban areas, is somewhat difficult to believe. But maybe things have happened nicely and all that data needs to be corroborated. Now, if at all the private sector patients are also being treated with government expense, then the sale of medicines in the chemist shop should come down drastically, because most of the patients in private sector who go to OPD, they are given prescriptions and there is huge amount of expense that people are incurring. And if there is a transformation in Rajasthan or anywhere else where most 70% of the IPD and OPD patients, both public and private sector, are being treated in with free of charge, then the sale of medicines in chemist shops should drastically come down, etc., etc. So I will not want to elaborate more, but I think all this needs to be discussed in some more detail, starting fundamentally with our conception of what do we mean by primary healthcare, secondary healthcare, and as Vandana has pointed out, all this is about medical care. I but I don't know, Vandana, whether antenatal care or immunization, it is in a sense medical care also. But anyway, so I think we need a more precise discussion with more precise data, the sources of which are available to us. Thank you.
Thanks, Anant. I'll just move to Purendra, and I want to bring up one point from the chat box, which is very important. Yeah, Purendra.
Yeah, since yeah, very insightful discussion, and I think thanks to John and Narendra ji, I will not actually take much time. While both of them gave a little more hope, and also I think Rajasthan seems to be an outlier, which cannot be actually seen, especially in South India, Telangana, Andhra Pradesh, and other states. I think all these insurance schemes are only fueling more and more privatization, aggressive privatization. In fact, to an extent that now nursing homes and middle level hospitals are also being taken over by the corporate hospitals. And in that process, I don't know whether there is any possibility of moving towards social insurance from commercial for-profit kind of drive. How would that actually happen is something that's one thing that I was actually thinking. This is true even in Kerala, where today I think Kerala also is moving more towards tertiary care rather than towards primary, and I mean, increasingly. I'm not saying that all of a sudden. So in that sense, out-of-pocket expenditure is actually increasing with more of these insurance schemes. Privatization is increasing. Small, medium hospitals in the small towns, medium towns are being taken over. And so that's the trend. I don't know how John would actually respond to the way in which we can actually move towards social insurance and make it more equitable and universal kind of a healthcare. Yeah, these are just the question, but I have more observations. I'll just leave it at that. Yeah.
Thank you. I'll take Kausalya's comment or question, add one point, and then go to Shom. Yes, Kausalya.
For HIV, actually, we are using it in Tamil Nadu for health insurance. that helps for us some of the expenditures reducing, scans and all the whatever in the government sector, in the private was sitting there. So that using for people more, and also for operations and things like that. It is actually useful to them. But nationally, the prime minister one, it is not working because the Tamil Nadu people from outside state cannot able to access for the CM insurance. So they have to use it for PM insurance only. So in that time, it is not actually for accessible for them. And the same time, people those who are still don't have a Aadhaar card, things like that, those people also accessing is very difficult for insurance. HIV medicine, there is no problem, but this actually for definitely needed Aadhaar card. Aadhaar card is not there, so insurance is not applicable for them. People in roadside and things like that, they cannot avail the insurance scheme. So that is actually one of the problems. So they have to go to any home, they get the insurance card. So we also draw some of the line for what is actually additional proceeding is needed for HIV positive people. So that we are actually dialoguing with them, but it is not happening immediately. So they said this time it is not possible. They said to us. Still, we are actually some of them case to case. We are helping them. That's all. Thank you.
Thanks, Sean. There's so much on chat that I can't, for obvious reasons, I can't track it all. I'm sorry for those whose messages I'm missing, but there are too many messages and long ones, so that will happen. I think one point though that I did capture was interesting and important. Ki it's not if people are taking social health insurance to the public sector, but the public sector needs that funding, the whole issue of irrational care and over expenditures and more investigations and drugs being utilized and all, that will remain. So I think that's an important point, that it's not only going to happen in the private sector. If the dependence is there on insurance for the functioning of the public health system and the overall budget of the public health system, then they will also do exactly that to capture as much as possible of the insurance. So that was just an interesting point. Somebody made that, and I just brought it up. So, Jean, I would like you to respond to all that you heard from them. And then there is one question to Narendra. I'll just put it to Narendra, that is there a cultural difference, Akshay asks, between Rajasthan and other states whereby this came about? So I thought that might be fun to answer for you, Narendra. So I just brought that up. So, Jean, over to you.
I'll answer later.
I was also not able to keep up with all the comments in the chat box. I thought I'll show one more slide. I'll just share my screen again. 1 second.
Yes, I think state level differences was something that you might want to show a slide on.
Yeah. There are of course huge.
Disparities are there, and we can go into that.
See the screen?
Not yet, but there's a little bit of a phase lag. And in case I bounce out of this, because I'm running two systems, both are running into difficulties today, and Rupa will take over till I come back from my phone.
You see the slide? No?
No.
Let's try again, 1 second.
It's a peculiar day, no, for technical issues. Yes. Yeah.
Yeah, you can see it?
Yes, we can see it.
Okay, so this is from the paper I mentioned with Anfaz. So it's the share of public hospitals in empaneled hospitals. So you can see enormous contrast between different states. I was interested in Karnataka because, as you can see, in Karnataka, according to this, 84% of the empaneled hospitals are in the public sector. I think part of the reason, and that would also apply to Orissa, is that Orissa and Karnataka are empaneling the PHCs, so that becomes a large number compared to the total number of hospitals. But I think I was interested also to hear whether Karnataka is also making a deliberate effort to use the health insurance schemes to promote the public instead of the private sector. And that's why I was interested in the referral system. So from what Prasanna said, I think it probably true, at least to some extent, that in Karnataka, and I'm sure that has been true in Orissa as well, even if it may or may not be true still today, that these schemes were used to try to promote the public sector. I think that's one direction in which to go. And then you can see that there are quite a few states where very few public sector hospitals are empaneled, and it's mainly private sector. Rajasthan is in between, is pretty close to the national average. People have mentioned the contrast between states. Of course, there are huge contrasts between states in all these matters. The one critical question I have about Rajasthan, I mean, of course, everything we heard is very positive and encouraging, but the question remains, what is the quality of care that patients receive? I mean, it's one thing to provide free healthcare in the sense of removing the fees, but the question is, what is the quality of care that people receive? And unfortunately, in the Right to Health Act in Rajasthan, there are no minimum norms. I mean, all it says basically is that the healthcare will be free, and then the norms are supposed to be prescribed in the rules, and I don't think that has happened yet. Personally, I would be surprised if the quality of care in Rajasthan is anywhere near what it is in most of the southern states, because Rajasthan is coming from a very long way. I mean, 20 years ago, Rajasthan's healthcare facilities were really abysmal. They have definitely improved, but at least at the level of PHCs and CHCs, because we have done surveys from time to time in Rajasthan on PHCs and CHCs, the improvement is not at all radical. I mean, it's pretty slow. Maybe it was much faster in the larger hospital. And in fact, Naren did mention that at the lower levels, there's still a lot of excess capacity and shortage of staff and so on and so forth. So I think the quality of care needs attention. And that's also why, as far as the health insurance schemes are concerned, I said that we really need to know more about the patient experience. I mean, what are they getting from these insurance schemes? And are they satisfied? Are they not satisfied? Are they being treated well? Are they being cheated and so on? There's far too little information on all this. So I think all these contrasts are there, including in the work culture. The work culture is paramount in the healthcare sector. And there again, there are huge contrasts. I mean, in Bihar and Jharkhand, the work culture is absolutely abysmal, as I have tried to illustrate recently by sharing experience at RIMS, the largest hospital in Rajasthan. And then some states have a much better work culture. And again, there, my question is, where does Rajasthan stand? But anyway, so I don't have answers to most of the questions that were. I think there was one question about how to move more towards social insurance. One thing I will say, I mean, I've already shared one or two thoughts, including giving priority to the public and private non-profit sector, and private sector being the last resort instead of the first resort. But I would also say that I think it's important to design these insurance schemes in a way that they don't become a one-way street. I think right now they are a one-way street. Right now they're promoting private healthcare. The private healthcare system, the profit-seeking private healthcare system is becoming more and more entrenched, and it's developing a vested interest in these schemes as they are. And I think that is quite dangerous, because I think it's important to keep the door open for the possibility over time, in the fullness of time, of reaching a truly socialized healthcare system. And in that respect, I think there's a problem right now. And that's why I was suggesting that the priority should be for the public sector, and the private sector should be the last resort. So I think there are some things one can do, but ultimately, how to deal with this private sector, and especially, it's not just profit seeking, it's profit seeking unregulated. Vandana mentioned that in the introduction. That's also very important to mention, because a few countries, not many, a few countries have a social insurance system that does allow private profit-seeking hospitals, for example, Taiwan. But even those countries have a very, very, very tight regulation of the private sector. So there's something there that is going to be quite difficult, I think, to overcome.
Thanks, Joe. I think, Narendra, yes. please, if you want to respond to that cultural difference issue and maybe the quality issue. Yeah.
Right. So cultural difference, I really cannot comment on because I do not see any difference in the culture of Rajasthan with its neighbors like MP or UP or uh, especially MP, UP, not so much with Haryana and all. But I don't know why things are so different than these two states. The other thing is about quality of care, which specifically John asked, and this is something very important. I can vouch, and this is what Sudhir, my colleague, is here. He can, share his own personal experience. Kavita, I don't know if she is here. Kavita's colleague, Pappu's father, got a heart attack, and he was shifted from his hometown Fulara to Jaipur, and he was insisting the ambulance driver to take his father to the private, and the ambulance was a government ambulance. So he said, "No, I can always take you to the government entity only." So he took patient to SMS hospital. And once they reached the cardiology department of SMS hospital, Pappu and Kavita both started telling me कि हमने पहले क्यों नहीं सोचा कि हम सरकारी में ही जाएं. We found it much better than most of the private hospitals of Jaipur. It was so very well. And similarly, here in Jaipur Medical College Hospital, things are so professionally organized that I get to find a patient who will complain that I did not get a better treatment from here. This is about the public sector I am talking about. Sudhir, if he is here, can always talk himself what his own experience has been. So what I'm trying to say is that things are becoming better in Rajasthan, and because of this universality, that competition between public and private has become completely removed. Private had to really struggle hard in order to fill up their beds. In fact, they are not getting patients. We have a fantastic private hospital constructed by the Birla Corporation. Its 2 floors have been never opened, only because not enough patients are going there because their fee structure is so very high. So what I'm trying to say is that Rajasthan is doing differently, but why it is differently? Of course, one of the things is that Rajasthan had been on forefront of everything in terms of people's rights. May it be right to health, right to employment, right to information, food security, and forest rights, everything. They all have somehow some link of originating from Rajasthan. So this has happened. It's one of the things which is happening like this.
वीरेंद्र जी, बिफोर यू गो ऑफ, एक सवाल है कि आप केरला और राजस्थान के मॉडल में क्या फर्क देखते हैं? दिस हैज बीन क्वाइट अ वाइब्रेंट डिस्कशन एंड डिबेट ऑन आवर ग्रुप्स आल्सो, मतलब स्पेशली सिंस lately we heard that Kerala is
केरला में तो यूजर फी भी है. केरला में तो आप प्राइवेट गवर्नमेंट हॉस्पिटल भी, इफ यू आर गोइंग दैट यू हैव टू पे फॉर इन्वेस्टिगेशंस. इन फैक्ट देयर वाज अ फुल फ्लेज्ड रेट चार्ट displayed outside a community health center showing that you have to pay so much for your blood investigations, and you have to pay so much. So Rajasthan, Kerala is very different. Of course, the Kerala GSDP and per capita expenditure on health is much more than Rajasthan for that matter. So I am sure qualitatively they should be doing better work than perhaps Rajasthan, but their out-of-pocket spending is also very high. So total overall spending on health is very high in Kerala, both public and private, both public and out of pocket. I mean private, I mean out of pocket. And I don't know if they have a better health indicator. So certainly they undoubtedly their IMR is less than 10, their MMR is so low.
and
But
maybe
of
that
course,
is
in terms of
not medical. Yes, yeah.
but in
No.
access to health, Rajasthan is doing much better than India.
Okay, I think some points from chat that have been reinforced by others also. One is कि we need to find out कि facilities में अगर social health insurance के जरिए से पैसा जा रहा है तो उनके overall budgets कट रहे हैं कि नहीं. मतलब how is it that the budgeting from tax is reducing and the health insurance is going up or are both going up? I think that's an important question, and we don't have the data to tell us that. And that's an important question raised by Swati. But here I would add that the route of going through insurance through a user interface is always going to be wrong from the point of view of a medical, from the point of view of medical rationality, overuse, and so on and so forth. So that I would caution that even if the budget finally that the facility receives is more through the patient, that's not a good system for medical care, in my opinion. And I'm saying this strongly because the patient does not know what good care is, quality care is. And if the facility is starved for funds from tax based funding, they will do the wrong things by the patient. There's going to be no distinction between private and public if the public health facilities do not receive tax-based funding. And if they don't, and there's a phase lag, why would anybody take the insurance to a badly funded, poor infrastructure place anyway? So they're either going to lose their patients and lose the money that's coming via the patients, or they're going to make that money, but they're going to do wrong things by the patient. So I mean, this is just my addition to this whole conversation, that there's no way that I can see social health insurance replace in any manner tax-based funding for medical care for people if we are to take care of quality issues. And resolving quality is very difficult. बहुत मुश्किल है कहना कि भाई इस डॉक्टर ने ऐसा क्यों किया, ये सीटी स्कैन क्यों प्रिस्क्राइब किया. It is almost impossible to take anybody to task. But if that doctor knows that they have targets, they have to put in that money, otherwise उसकी नौकरी जाएगी, अस्पताल बंद हो जाएगा. So I think there is just no way that a user interface contribution to a health facility can ever work for good quality, rational, non-over medicalized services. So that is just something I wanted to bring in. The other thing that I think important point discussion में जो आया है कि जमीनी स्थितियों पे बहुत कम काम है. मतलब इसका उभार, जो जमीन पे काम कर रहे हैं वो रोज देखते हैं, लेकिन इसको डॉक्यूमेंट करना, इसका मतलब डेटा में भी और फॉर्मल रिसर्च में भी बहुत कमियां हैं जो इस पूरे कॉन्वर्सेशन में आई हैं कि इस टाइप का डेटा हमें नहीं मिल पा रहा है, आउट ऑफ पॉकेट एक्सपेंडिचर्स का डेटा. आई थिंक इंद्रनील रेज द पॉइंट कि कैटास्ट्रोफिक एक्सपेंडिचर इज मोर व्हेन पीपल आर यूजिंग इंश्योरेंस, बट वो डेटा मैंने तो देखा नहीं है और वो बहुत जरूरी डेटा है, मैंने बहुत ढूंढा है कैटास्ट्रोफिक एक्सपेंडिचर का डेटा, लेकिन वो डेटा नहीं अवेलेबल है. तो मतलब फॉर्मल लार्ज मैक्रो डेटा सेट्स भी बहुत कमी है इसको समझने के लिए, और जमीनी क्या अनुभव है बहुत महत्वपूर्ण है. एक तरीके से, एम आई मिसिंग एनी रेज्ड हैंड्स? अदरवाइज आई एम गोइंग टू क्लोज क्योंकि हमारा टाइम भी हो गया है. अगर अब किसी को बोलना है, ये लास्ट 5 मिनट है, तो आप अपना हाथ खड़ा कर दीजिए या चैट में डाल दीजिए. चैट बॉक्स का रूपा प्लीज ट्राई टू एंश्योर दैट द चैट बॉक्स इज आल्सो कैप्चर्ड, बिकॉज इतना रिच उसमें कॉन्वर्सेशन हुआ है, तो वो हमको संभाल लेना चाहिए क्योंकि किसी को नहीं समय मिला होगा उसको अच्छे से पढ़ने के लिए. तो लेट्स ट्राई टू कैप्चर द चैट बॉक्स, एटलीस्ट कॉपी पेस्ट इट. So these are the issues, but I think that one point for us as campaigners, as workers, as activists, इसकी ये एक्चुअल एक्सपीरियंस क्या है. इसमें जो मैं कहना चाह रही थी कि राजस्थान में मैं भी जो फील्ड में घूमी हूँ, एक्चुअल एक्सपीरियंस के कई अच्छे उदाहरण मिलते हैं, लेकिन बाय नो मीन्स इज दैट गोइंग टू बी कॉम्प्रिहेंसिव. मतलब माइग्रेंट्स के साथ क्या हो रहा है, और जो कार्ड कहीं भी नहीं बना पा रहे हैं, जो अपना, जिनके पास राशन कार्ड नहीं है और वो पीएमजेवाई नहीं मतलब जुड़ नहीं पा रहे हैं, इसमें क्या हो रहा है, ये सब बहुत कमियां हैं. एक इलाके में जहाँ पे मैं गई थी राजस्थान में, करौली जिला में, कुछ लोगों का बहुत मतलब ऑपरेशन हो गए और बहुत खुश थे कि हमने एक पैसा नहीं दिया, हमारा बहुत अच्छे से ऑपरेशन हो गया. उसी गांव में सिलिकोसिस की का प्रभाव बहुत था. एंड मतलब वही इंसान मुझे ये भी बता रहा है साथ साथ कि यंग विडोज ऑफ 20, 22, 23, तो उनके लिए तो कुछ नहीं है ना इसमें. तो वो किसी भी हालत में, मतलब हम यूनिवर्सल हेल्थ केयर तो नहीं अचीव कर रहे हैं, और ये तो मेडिकल है, मतलब सिलिकोसिस इज अ क्रॉनिक मेडिकल प्रॉब्लम. So we are not even achieving, as Anant correctly stated, that it's not even that we are achieving good medical care. Whatever we are achieving is medical care. It's not comprehensive medical care. It's not primary level medical care. It's by no means rehabilitative medical care. And we are not getting anything on, like, it's not meaningful for maybe preventative care. You can call all of this medical, मतलब immunization भी medicine में भी आता है, you can, but I think what he's saying is right कि हमको अभी उस तरीके से ना देखते हुए कि भाई medical, non-medical, health, medical, it's better to look at the levels of care, primary, secondary, tertiary. वो हमको ज़्यादा स्पेस दे, मतलब हमको ज़्यादा एक सही मापदंड देता है. It's a better framework, which I totally agree with. I think Jean has given us a framework to look at social health insurance per se. What are the characteristics of good social insurance? ये हमारे लिए बहुत महत्वपूर्ण हो सकता है। मतलब ये जो उन्होंने 6 बिंदु रखे, उन्होंने बताया यूनिवर्सल, नॉट फॉर प्रॉफिट, और उसमें भी मतलब डिस्कशन हुआ है, उसको हम और वो कर सकते हैं, उसको मॉडिफाई कर सकते हैं, अडेप्ट कर सकते हैं। लेकिन वो एक अच्छा फ्रेमवर्क है शुरुआत के लिए हमारे लिए, कि हम सोशल हेल्थ इंश्योरेंस को ही किसी तरीके से इवेलुएट कर सकें। अगेन आई एम लुकिंग टू सी एनी हैंड्स, एनीथिंग। Last few minutes for people to speak up, those who have not. And Anfaz, you had worked with John. Do you want to say something in particular? Akshay, also, I would like to ask in particular, do you want to say anything? Indranil, who has been working on insurance for a long time, if you, all of you have anything that you want to add, please. ज़मीन की आवाज़ें बहुत ज़रूरी हैं, या उठाना कुछ आई हैं, बहुत नहीं आई। हाँ, कुछ बोलना चाहें तो अब आप लास्ट हम 5-10 मिनट में फिर इसको समाप्त करेंगे।
There's a hand raised.
हाँ, बताइए।
I think
Just call.
Anandji,
हाँ
Anandji is there.
हाँ, बोलिए प्लीज, मेरे को आपका नहीं दिख पा रहा है। हाँ, बोलिए।
Yeah, Anandji, would you like to go? I have a hand raised.
Yeah, I have just sent a small question in the chat box that 40% of the expenses for universal healthcare have to come from the central government. Now, assuming that Rajasthan government is largely fulfilling its role of 60% contribution, I don't know whether they really done it. That one has to verify. But it is absolutely clear that the central government is spending only 1/3 of what it is supposed to do, if you see the government's budget. So when there is such a gross positive deficit in the central government spending for healthcare in Rajasthan, how can we talk about universal healthcare? You cannot make a march towards universal healthcare with such a absolutely pathetic spending by the central government. So I think all this talk about universal healthcare march towards in Rajasthan has a big limitation of paucity of funds from the central government. We can't overcome, we can't neglect that and just keep focusing on what the Rajasthan government has done.
Narendra, would you like to respond? I'm not sure I got that point. तो नरेंद्र, आप अगर इस पे कुछ
मेरे को भी थोड़ा आधा अधूरा जो समझ में आया वो ये है कि देखिए,
नरेंद्र हमसे कट जाते हैं।
हाँ, मैं ही कह रहा था कि ग्रॉस डोमेस्टिक प्रोडक्ट है दैट इज हायर देन मेनी ऑफ इट्स, सो available part is this. It's not
नहीं हो पा रहा है नरेंद्र जी, नहीं समझ में आ रहा है, नहीं कुछ सुनाई दे रहा है। कुछ लोग जिन्होंने मतलब जैसे डिस्कस में रिस्पॉन्ड किया था, मैं उनसे खास पूछ लेती हूँ। हाँ, आप टाइप कर लीजिए।
आवाज आ रही है?
हाँ,
यहाँ से आवाज आ रही है क्या साफ?
रामेश्वर, हाँ रामेश्वर जी बोलना चाह रहे हैं क्या? बोलिए।
नहीं, साफ आवाज आ रही है क्या?
नहीं, नहीं आ रही है, तो मैंने उनको बोला
नहीं
है
आ
कि
रही।
आप चैट बॉक्स में टाइप कर दीजिए। नहीं आ रही, किसी को भी नहीं आ रही है, तो वो नहीं हो पाएगा शायद नरेंद्र जी से रिस्पॉन्स। हाँ, मैं पूछ रही थी कि अक्षय आप कुछ बोलना चाहेंगे? अनफाज, अक्षय,
No, no.
सुंदर। हाँ, अक्षय बोलिए। हाँ, अच्छा, अक्षय नहीं बोल रहे हैं। अनफाज, आप कुछ बोलना चाहेंगे? एनीथिंग you'd like to add? Is Sundar still here? Would you like to contribute to the conversation?
No, Dr. Sundaraman is not here.
Okay.
Vandana, may I say something?
Please, please. Veena, is that? I don't.
Yeah, I'm Veena here. It's
yeah.
just that it's such a huge area that one is thrown by what it entails if our new states or existing states would really like to firm it up. And I think Jean's points are very, very valid, except that we have very few non-for-profit hospitals in this country. But it's a fascinating idea. My whole thing is the work. Think of the migrant labor, okay? 78, 90% of the workforce. What's happening to them? I think Kerala has some scheme, but I do not know about others. Think of the quality of care, yes, but also standard of care. I mean, that's not the right word, rational, irrational. Uh, I think this group will have to set up a dossier or a subgroup that will have to work on many, many fronts, because you can go to a hospital which needs to take your money and just have any amount of investigations going. A CT scan almost every day could be one example. But yes, what would be standard? Is that the right word, standard of care or rational care or
Absolutely, yeah.
yeah. So somebody will have to work on that. Somebody will have to see that everyone gets registered and the mistakes that were done in the right to food group must not be repeated here, where digitalization takes over our lives and people are now no longer available, I mean, no longer valid human beings in many of these remote areas. Connectivity, transport. I mean, we need so many subgroups to work on this that I really don't know. The whole area is so vast. And Narendra, it would have been so good. Referrals, I mean, what are the areas where referrals are done without any hidden costs in it? You need subgroups working in each of these areas. And honestly, thanks a lot. Learned a lot, and there's so much more to do as far as I can see. Thank you, Vandana.
Thank you, Veena. Just to see
हेलो
मालिनी
वंदना जी
मालिनी हाँ बोलिए निसार हाँ बिल्कुल बोलिए
I just wanted to add that central government is actually not spending even 40%. It is spending 40% in selected centrally sponsored schemes only, like NHM. But if we look at the entire state budget of going towards health, so a state's share will be much higher. Salaries are all paid by the state governments. So 40% contribution which the central government is making, it is only making towards the selected centrally sponsored schemes like National Health Mission. Obviously, central government is also allocating funds to central government hospitals like AIMS, etc. But yeah, there is a valid point that central government's allocation towards health remains very low.
Thank you for that clarification. Inayat, Malini, anything that you'd like to say? Otherwise, I'm going to just briefly give it to Jean if he has any response to the discussion, and then we will close. I mean, it's only 7:05, so we haven't done badly at all for time. Inayat, would you like to say anything? Malini? And apologies if I've missed anybody who's been talking on this in the JSA discuss, and I may well have missed you. I'm sorry. Please raise a hand if you would like to speak. Swati, did your question get kind of addressed, or do you want to also say something, Swati?
I
Swati,
think
yeah.
it got addressed a little, but like you said, I think maybe the numbers are not available. What I was going for was earlier, if the budget allocation to the hospitals were X amount, and now they've stopped that and they're doing it through the state insurance or the PMJAY, then the whole point of argument that this will strengthen doesn't hold true
Yes.
at all, because that's the fund that they anyway deserve and that's the fund they should get. But instead, it's getting diverted to the private sector. So,
Correct.
yeah, but I couldn't get these numbers.
Yeah, they're not there. Anfaz, you worked on the study with Jean. Is there anything that you'd like to add that stood out to you as somebody who was studying this while you were studying it? Was there something that really struck you, since you might have looked at it with slightly fresher eyes than all of us? Anfaz?
I think he is busy with a visa interview. So,
if
That's
I
great.
may, I was not able to raise hands. I don't know why.
Who was that? Yeah, speak. Yeah.
Raj
Please,
Lakshmi.
please, Raji. Yeah.
Yeah.
Go ahead.
So in terms of plans of action, I was thinking of two things. One, as a group, there's so much of unpacking we have to do to even criticize the insurance model, how it works, how the trust model works, what happens when there's a hybrid model, etc. So if we can have a couple of more follow-up webinars with people who can help us unpack that, then that strengthens us to collect evidence. And the second thing is, Jean was asking what's next. We could do is, I have tried to get data from the Tamil Nadu government. They shared it when I was a doctoral candidate, but now there are lots of, pushing back that's happening, especially quoting that since it involves private players, this is not a this doesn't completely come under RTI. So I think we need to challenge this, and without data, it's so difficult to also, criticize aspects of this. So is there anything we can do as a group to file an RTI or a PIL asking for just data, even if it is 10% of the raw data, it would still be a huge number to work with.
Thank you, Raji. I think that, chat box, maybe follow-up webinars is something that's come up. I could help to organize if somebody could identify exactly what, specify, and find speakers who have some, information. We could help to do that. I don't, at this point of time, know of anybody who would be able to specifically contribute, but that doesn't mean that they're not there. So if anybody has suggestions and advice, we can take it forward for sure. I don't think this conversation should stop here. But at the same time, for group action, we'll have to talk within whatever groups we are in, because this is a nebulous lot of people. We're not necessarily organized around any single group. And what action we can, I think there are ideas here for action, and you have provided some, putting in RTIs, doing more research, bringing in voices from the ground. There could be public hearings. I can think of, there are lots of possibilities. There are people here who are taking leadership positions in taking action forward, and I'm sure that they have got some ideas from here. And if anybody is inspired to do the next webinar and to host it, they should just go ahead. I don't think we should wait for anybody to do things. इस देश में मतलब स्वास्थ्य पे जिसको जो दिल कर रहा है करने का, कोई मोटिवेट हो रहे हैं, कुछ आइडिया आ रहा है, प्लीज उसको कीजिए. See, I just invited people. Almost 100 people have come and to this discussion. People are really wanting it. तो प्लीज आप लोग ये चर्चाओं को आगे ले जाइए. इसमें किसी को आइडिया है, मैं या PHRN मदद कर सकते हैं, हम जरूर करेंगे. We're all there for you, but don't wait for anybody to take leadership, क्योंकि वो this is not, I mean, like, we need all of us to take initiative. So as and when whoever can do anything, that's what we do. I think going forward there's a lot. I'll just list out जो हमारी चर्चा में going forward हुआ है. पर उसके पहले Jean, any last comments from you, please? Yeah, are you still there? I'm sure people are tired now. It's been very intense, so मैं खुद थक गई हूँ. Jean?
No, I don't have much to say. I think having public hearings or just discussions at the state level would be quite useful, because as we mentioned earlier, all these things are very different in different states. And my hunch is that many of the state schemes are worse than PMJY. I mean, certainly in Jharkhand, I think that is the case. So I think there's a lot of scope and need for discussion of the state schemes, and that must involve some kind of ground research, and then maybe public hearings, and then maybe consultations at the state level. It may not be possible to do it in every state, but even if we can begin in a few states, I think that will give some kind of momentum. Unfortunately, in Jharkhand, it's very difficult to do because there's hardly any health activists here, but I'm sure there are places where it can be done. Sorry.
Is Sanjay still here? Sanjay Nagral? Has he left?
He's left. He's not there.
ओके, तो देखिए कुछ बिंदु जो मतलब ये पूरे ही डिस्कशन जो चल रहा है काफी हफ्तों से, जैसे डिस्कस व्हाट्सएप ग्रुप्स, यहाँ पे बातचीत हुई है, उससे आगे की जो बातें मैं बस उसका आई एम जस्ट समराइजिंग इट। एक आध चीजें जो नहीं आई है उसको भी मैं समराइज करना चाह रही हूँ। एक जो चीज अभी तक यहाँ पे आज नहीं कही गई है, बट इट्स इंपॉर्टेंट, समथिंग वी कैन ऑल डू इज गो विद आवर पेशेंट्स एंड कॉन्टैक्ट्स टू पब्लिक हॉस्पिटल्स। जो जॉन ने करके एक केस स्टडी एक कहानी भेजी, फिर औरों ने अपनी अपनी कहानी बताई, उसमें अच्छी कहानियां भी निकलेंगी, उसमें बुरी कहानियां भी निकलेंगी, एंड थोड़ा सा कॉशन की मतलब big hospitals and big cities are not at all necessarily representative of what गांव में क्या हो रहा है। तो ये एक चीज है जो मुझे लगता है कि थोड़ा सा एफर्ट अगर हम कर लें, कि हम कम से कम जाके देखें तो सही, कभी कभी किसी पेशेंट के साथ कि भाई क्या हो रहा है, कैसे केयर मिली, वहां पे जाके हम थोड़ा हल्ला भी कर लेते हैं, कुछ हो भी जाता है, कुछ नहीं भी होता है, लेकिन वो एक हमारा कनेक्ट तो बना रहेगा कि जमीन पे क्या हो रहा है। So I think that is extraordinarily important. It's not the most difficult step to do. In fact, it's one of the easiest things. It's not easy either, I know, but it's one of the easier things to do than taking very organized action. But at least let's follow some patients to public facilities. अगर खुद जाके पब्लिक फैसिलिटीज में केयर लेने की तैयारी हो तो वो उसको प्रायोरिटाइज करने की कोशिश करें। ये नागराल एंड अदर्स मेनी पीपल हैव सेड कि हम लोग तो मिडिल क्लास ने जाना ही छोड़ दिया है, हम में से बहुत से लोग नहीं जाते हैं। तो that is something to remind ourselves to do as part of our work. पब्लिक हियरिंग्स की बात किस में ताकत है पब्लिक हियरिंग्स को ऑर्गेनाइज करना। यस, जो वीडियो टेस्टिमनीज ऑफ पेशेंट्स एक्सपीरियंस विद, एंड ये अभी हम आंगनवाड़ी के संदर्भ में अभी ये बातचीत चल रही है चिल्ड्रंस राइट टू फूड में, कि आंगनवाड़ी कार्यकर्ता के मतलब उनके अनोनिमाइज्ड हम वीडियो नहीं ऑडियो, जिससे कि वो आइडेंटिफाई नहीं हो सके। आंगनवाड़ी कार्यकर्ता इतना दिक्कत महसूस कर रहे हैं। तो इस तरीके के वीडियो अगर कोई राजी हो बोलना अपनी कहानी, शायद यूजर्स विल बी विलिंग फॉर वीडियोस एंड वर्कर्स विल बी विलिंग फॉर अनोनिमाइज्ड ऑडियोज। इसको यूट्यूब्स पे शेयर करते जाना आजकल तो सोशल मीडिया का बहुत प्रभाव है। तो ये इन कहानियों को मुझे लगता है हमको और लाना चाहिए इसमें। प्रेस एंड मीडिया, यहाँ पे रेमा थी, कई से और लोग थे। तो इस टाइप के ह्यूमन इंटरेस्ट स्टोरीज, डेटा एंड रिसर्च जो हम लोग एकेडमिक इंस्टीट्यूशंस में, या नकीरन है, इंद्रनील है, रिचा है, और भी बहुत से लोग हैं, रिसर्चर्स हैं, ये जो डेटा गैप्स हैं इस पे खास तौर से काम करना। पीएचआर एंड मतलब समीर एंड SHSRC में काफी काम इस पे भी हुआ था, बहुत पब्लिश भी किया है समीर ने अभी हाल में। इस टाइप का आउट ऑफ पॉकेट एक्सपेंडिचर्स, कैटास्ट्रॉफिक एक्सपेंडिचर्स, एक्चुअली बजट्स में क्या हो रहा है, फैसिलिटी वाइज बजट्स को क्या हो रहा है, इस पे ये है ही नहीं ना इन्फॉर्मेशन जो स्वाति बोल रही। तो इस पे बहुत स्कोप है हमको एकेडमिकली काम करने का as researchers. And so these are the things that I think moving ahead, more conversation for sure. Please initiate where I see that I can, when I understand something and I feel ki, yes, I can do this, I can call for a webinar and it will be meaningful because I can organize it. I know who can contribute. I will definitely go ahead and do it. If people give suggestions, we also don't have too much bandwidth because we are also spread thin, but we will try to help, but don't depend on us for leadership. Just because this one has happened doesn't mean the second and third Vandana only has to kind of mobilize. Please feel free, and we're there for support. Anybody contacts us for support, we will definitely try to support each other. We always do. And shall I close now? It's been wonderful. Thank you so much. I think we had nearly 100 people here, and many have remained right till the bitter end, which is a great sign. We still have more than 50 people. We stuck to time. I think we did meaningful work. Just please join. Narendra, let us know if we are able to circulate your PowerPoints. Would that be all right? But anyway, the recording, we would like to make that recording available. I think that should be fine. With circulation of PowerPoints, if you have an issue, we understand. Just let us know specifically whether we can. Many people ask for that, but they would have the information available from the recording. So I think that would also be fine. So just let us know. And yeah, I guess we just carry on.
कई
Fighting.
लोग वंदना जी ज्वाइन नहीं कर पाए ग्रुप्स में,
हाँ,
कई लोग लिख रहे थे तो उनका भी कहना था,
हाँ,
कई सारे लोगों का है।
बहुत से लोगों ने को, या आज सबको दिक्कत रही है, मुझे भी दिक्कत रही है, मेरा एक लैपटॉप भी क्रैश हो गया, ब्ला ब्ला। तो नरेंद्र को दिक्कत रही है। तो हम रिकॉर्डिंग तो दे ही देंगे। और मतलब जो लोग यहाँ पे सेक्रेटेरिएट्स का हिस्सा है, कोऑर्डिनेशन का काम निभा रहे हैं और लीडरशिप की भूमिका में है, आप समझ रहे होंगे कि आपको मतलब इसके आगे आप क्या कर सकते हैं और क्या करना है। सो please take things forward, which you have committed to also on the chat box. So that is excellent. Anything more, or can we close now? I hate to, मतलब जुदाई में भी मुश्किल होती है ना, बंद करने में भी मुश्किल होती है. So please put your videos on, and we can just say wave hello and say bye to each other as we leave this webinar. Please try to put your videos on, put your audios on, and let's see each other. Let's be happy that we are all present together here today. Hi Meera, so good to see you. Hi Nita. Yeah, lovely to see everybody. Really, take care, everyone.
Yeah, we
Keep
should carry forward this
yeah,
conversation.
let's do it.
There are
Let's
still
do
lots
it.
of misconceptions. We'll have to clear it up. Yeah, I mean, we
Yeah,
should do that one more round. Yeah.
but glad to find Rajasthan group so optimistic, and but I think there is something there. It's not the complete picture. Undoubtedly, it's not the
Yeah,
complete
yeah.
picture. But कुछ तो हुआ ही है. And yeah,
Cool.
so cool. Bye bye, everybody.
Bye.
Thank you so much.
Bye.
It's been great. Yeah,
Bye.
yeah. Lovely to meet. चलिए फिर मिलेंगे. जिंदाबाद. करते
Thanks, everyone. Thank you, John. Thank you, Narendra.
Join.
Thank you.
Yeah. Let's just clap for Joy and Narendra. They were fantastic. And yeah, I don't know whether Narendra is still even there. पता नहीं, वो दिख भी नहीं रहा है. तो सब कोई ताली बजा सकता है. Bye. Thank you.
Bye.
Lovely. Take care. Yeah. Bye.
Ananya, just stay back. Ananya, you need to make me the host.
You're on mute. Oh,
Bye. Yeah.
I
I need to save the video, so I just wanted to be the host for that.
You're in a very bad shape, so we didn't turn off our videos. It's
7
really
o'clock in
hot.
the evening, yeah. It's okay.
Yeah.
Hello, we'll catch up, yeah.
Okay, ma'am. Bye. Bye.